We're pleased today to have David Kendrick with My Health Access Network. He's going to talk to us today about health information exchanges, HIEs. And so, guests, before you speak, would you please introduce yourself into the mic, and then you can start your presentation.
All right. I'll start from here then and wander up to there and back down again. Try to stay in the mic. All right. Well, so I'm a physician. Obviously, I practice internal medicine and pediatrics. Studied engineering before medicine, and have degrees in public health and board certification in something called medical informatics, which is sort of engineering meets medicine. And I'm on faculty at the University of Oklahoma and at the School of Community Medicine in Tulsa, where I chair the Department of Informatics. So I'm a state employee in that sense. But I also am a consultant to a number of projects, and one of the projects I consult for is in the role of CEO for this effort called My Health Access Network, which is a nonprofit health information exchange that was started much like you might start a food pantry in your community or a homeless shelter to meet a specific community need for Oklahoma, which was to help health records move securely where they need to go. Maybe a bit more technical problem than other nonprofits, but no less a nonprofit nonetheless. I also, just by way of disclosures, I'm on the board of an organization called NCQA, the National Committee for Quality Assurance, which I chair, and that sets most of the rules around quality measurement for the country. It's also a nonprofit, and then also on the board of a couple of other organizations. The fundamental issue we're trying to solve, one of them at least, is this, right? That we spend twice as much on healthcare in this country as other nations, and we're going to have a difficult time if we aren't already competing in world markets and for workforce, et cetera, as long as we continue to outstrip spending. So this shows, of course, the OECD countries, and there we are at the top, spending more than most in the private sector. But when you layer on our public sector as well, we're spending double most other countries in the OECD. Which would be okay if we were getting what we're paying for, but we're not, right? We all know life expectancy in this country is not what it could or should be. In addition, morbidity, quality of life is not where it should be as well because of these issues. And as you can see, despite our increased spending, we're getting less and less for what we're spending money on. In healthcare. This is a graph that sort of has defined my career for the last decade or two, and that is the U.S. healthcare spending as a percentage of GDP. And what it shows is there was an event in the 90s, and some of you may remember that. I certainly remember it, but there's some younger than me that may not. But there was an inflection point in the mid-90s where healthcare costs stopped rising at such a rapid rate. Does anybody remember what that was? That was the point where we made a hard shift towards across-the-board managed care, not privatized managed care, but starting to pay for outcomes and having providers take risk. Okay, and the reason that's an important moment in time is because it stopped. Why did it stop? Because patients hated it. Because we had gatekeepers, remember that term, gatekeeper physicians, and it turned out that because there was no infrastructure to support this kind of payment, where providers got paid for the outcomes they got, measurement was not good, there was no data that moved, there was no way for a patient to decide what kind of quality they were getting when they were going to a provider. And so ultimately that system collapsed with primarily patient dissatisfaction because care was just being withheld to save money. Right? It was just that you couldn't get the colonoscopy you needed, or you couldn't get the dermatology visit you needed. But look what happened as soon as that model came apart. Costs started going up again, reliably as ever. And so there's been discussion, a lot of discussion in Washington and other parts of the country as well about, well, what are the best things about that time and the worst things about that time that we can leverage? What are the components of that? What made it not work? Clearly it saved money, but if it saved money by withholding care, that's not good. Clearly there was some glimmer of hope in that. And so the term value-based payment models has come to be discussed, and hopefully you guys have been discussing it some in this committee. And that's the notion that we pay for the outcomes we want and not just for the widgets, meaning the number of office visits that I might do every day or the number of surgeries I might do every day, but we pay for the outcomes I get. in my operating room, or the amount of blood pressure I get under control, or the amount of diabetes I get under control. And so that's a very different perspective on this model, and it becomes kind of the fundamental equation in building new healthcare payment models and delivery systems around them. And the reason I start at this level when this conversation is really about data is because data underpins this model. Without the appropriate information on a timely basis, we can't answer either of the two variables in this equation. You know, it's value is quality divided by cost. So that means if cost goes up but quality doesn't improve, value's going down. The patient and the nation are getting less for their dollar. If quality goes up and cost stays the same, value is going to go up, right? And so this is a pretty fundamental thing. And if we think about how we operationalize that, how do we make this the way we do care, deliver care in America today, we have to think about it like this. Quality, you know, cost is relatively easy to get at. That's how many dollars went out the door to pay all the doctors and the hospitals and the clinics and the transportation and the meds and everything else related to healthcare. It's the top part that's hard to get at. What about health outcomes? How do we measure how many people in Oklahoma have their blood pressure in control and out of control so we can know if 10 months later we improved it or not? And that is where we come back to data. And then, of course, satisfaction, which is the perception of the quality of the services, which are important. I would say my satisfaction has got to be very high with my primary care provider, but if it's the best surgeon in the world, I don't really care what their bedside manner is. I just want them to cut on me and do my surgery, right? Because they're the best. So it kind of, that's got a little bit of variability in it as well that is best helped with data. So value-based payment models are here to stay. As I'm sure you're aware, there were really two components to what I think most in Oklahoma refer to as Obamacare, or the Affordable Care Act. The one piece that was most in debate and remains in debate was how to pay for health care itself, you know, how to get people coverage. And I'll set that to the side for the moment. The other half of that legislation was about how do we pay for care, how do we pay doctors and hospitals. And value-based payment models have really been the consensus that everybody has landed on both sides of the aisle. You can see the votes were almost unanimous, and demonstration projects are showing really positive results, including, as I'll show you, here in Oklahoma. And there's already begun to be significant private sector buy-in on the commercial payer side. So there's another issue that we're running into in healthcare, and that's the term provider burden. And providers have a lot of stuff put on them. So each doctor and hospital accepts dozens of different insurance plans, right? Each insurance plan requires a different kind of paperwork, a different kind of authorizations, a different kind of set of quality measures for performance, and a whole different thing to be reported on. And then we've added to the regulatory burden. We've got the Meaningful Use Program, which requires us each to use electronic health record systems. And this is important as well. As we know, for transformation, you've got to have the data. To get the data, you've got to have electronic systems. So we've moved most of the nation onto electronic systems now, which is great, but it brings with it additional burden. And then you've got the quality improvement programs, licensure, board certifications, continuing education, student loan debt, etc. Poor doctors. I say that tongue-in-cheek because there's a lot we can do there. The other thing that's really should be important, most important to you as a patient and as those who are setting policy for patients, is the pace of new knowledge in healthcare used to be doubling at the rate of every 50 years. And most recently, it's estimated to be doubling at the rate of every 73 days. Okay? So, to the top two bullets, 30% of U.S. healthcare spending is just for the overhead that all that additional payer and complexity paperwork layers in. 30%, right? Physician burnout costs about $4.6 billion a year because it causes early retirement, which especially affects our rural areas and our underserved populations, and it costs that much money to retrain and reposition providers where they need to be. And then on top of that, as I said, medical knowledge is doubling every 73 days, which means, every 3 months I'm out of date if I'm not reading literature every night. I would have to read 7 journal articles a night to stay up with what I need to keep up with. So we've got to do something about this. Something's got to give. This is a study published out of my department at OU in Health Affairs, and what it showed, what we just determined was that in these value-based payment models, there are situations where we could be disadvantaging providers, particularly rural providers and independent providers, because they don't have a big IT shop. They don't have an epidemiologist or a biostatistician on staff to help them report their quality measures, right? So we have to take that into consideration when we're thinking through this challenge. So here's the issue with data in healthcare. It comes in several major buckets or categories. The first is claims data, and we've had it the longest. Claims data is generated when I file a bill, right? And I put diagnoses or procedures, who the patient saw, when they saw them, and where they saw them in this bill. It goes to an insurance plan or Medicare, and it gets paid or not. We say that data is a mile wide, but it's an inch deep, because it tells me something about every event that occurred with the patient, but not what the lab result was or what the blood pressure is, right? So that you can't really measure whether the outcome was achieved or not in that. And then, of course, there's the out-of-pocket, which we don't have a good way to measure. But then you talk about the places where a patient goes to get care, in the clinic, for example. And now, thanks to Meaningful Use, every clinic has an electronic health record system. So that's the clinic EHR1 there. But it turns out that real people get care in multiple places, right? You can all think about the number of doctors you or your family see, and you should understand that everybody's like that. And so the situation we have in Oklahoma and everywhere else in the world, frankly, but certainly in this country, is that our care crosses many boundaries. Unfortunately, the data doesn't move across those boundaries. And so each doctor that uses one of those columns, which we say is a mile deep but only an inch wide, can see the details of the blood pressures and the lab test results, et cetera, but only within that one electronic health record system, right? You add to that the notion that about 20% of people churn or change commercial insurance every year, and you start to see that even the claims layer itself is fragmented. And that's an important first theme to this presentation is how do we deal with this fragmentation of information? Because as long as it's fragmented, you can't deliver high quality care, and for your purposes, you can't measure it, right? So we've actually quantified the fragmentation of data in Oklahoma to the extent that we have connected the hospitals and the clinics around the state, and we normalize the identities or take all the David Kendricks from the various systems and tie their record together so there's one record for David Kendrick, right? And what we've shown is that 70% of Oklahomans have data in 2 or more places. And that's a very conservative estimate, because you can imagine as more places get connected, there's more fragmentation. This is correlated well by a study done in the Medicare data set that shows that the average Medicare patient sees 7 different doctors a year, which means that the average primary care doctor, the average primary care doctor has to coordinate care with 225 other doctors in 117 other organizations. Now, what other industry takes their apex professional and says, your job is to move paper around, is to coordinate this much work? So it's no wonder to me that we have as many mistakes being made, errors, and poor quality events occurring, because we've set up a system that's impossible to work in. Just one of the lessons I learned well in engineering is the most skilled individual paid the most money can completely be undone by a bad system. And that's what we put them in. It's a bad system. So we've got this 70-30 split there. You add one chronic disease like diabetes, the number climbs to 86%. You add another chronic disease, it goes to 100%. 100% of people have their data in at least 2 different systems, and you can see how many other systems in the histogram there. Now, one of the things that we are often told is that if I use a particular electronic health record system, say Epic or Cerner or one of these, then because they're connected to each other, it's as if my records can move from one place to another. And we see a fair amount of data moving in that way. The problem is, when we take the data that we have and we divide it out by EMR vendor, what do you think the split is? It's the same 70-30 split, right? So even if everybody were on a particular system, it would not solve this problem. We've got to go bigger than this. We've got to think community-level infrastructure to address this. So the solution that's been worked on now for a couple of decades is to create health information exchange. And I should hasten to add, because we got on the wrong side of this label in 2010, this is not a health insurance exchange. That was a label from the early days of the Affordable Care Act that we basically had to start calling ourselves a network instead of an exchange, because that word was too confusing. But in health information exchange, it's basically an entity that sits in the middle, and every organization, hospitals, clinics, health departments, and so on, pharmacies, send the medical record, the information on the patient to that central system where the identity can be resolved, meaning, all the David Kendrick's records tied to David Kendrick and so on. And the data can be cleaned up and organized so that the next place the patient goes for care or services is aware of their history and can make decisions that don't make mistakes. They're aware of the drugs they're allergic to. They're aware they've already had this surgery or that imaging study done. They've already been on this medication, so they don't get prescribed it again. And that's a very important thing to have when you're making decisions or recommendations about treatments that affect what people put in their bodies, for example. You got to get it right. So the strategy behind Health Information Exchange, in particular with MyHealth, has been to do this, is to provide infrastructure for improving health, reducing costs, and supporting transitions from fee-for-service to value, to collaborate and partner extensively, so reducing provider burden. We've got to help rural and independent providers play just as tall as if they were in an urban setting or in a big hospital. I mean, I'm from a smallish town, and I know that a provider shortage hits there first. And being able to count on the same quality of care in a small town as in Tulsa or Oklahoma City is important. Protect the health of every individual. This is sort of table stakes. The health data is obviously protected health information for a reason. Most people, healthcare is usually about 20, 25 years behind other industries, right? We always say that we're banking in 1965 right now as we're starting to put these connections together. But we had sensitive data and no guiding law as to how we should manage it until HIPAA came out. So while a lot of people think HIPAA complicated things, it finally gave us bright lines between which we needed to steer. And so we're able to leverage the rules in HIPAA to exchange the data securely for treatment, payment, and operations, which are the guidelines in HIPAA, but also for the first time to be able to provide patients back and answers to everywhere their records have gone. Who has seen their records, right? I mean, this is the right of every individual, is to know how their data is being used and where it's going. And so this, we say middle tier, this health information exchange layer, can do these things. And by the way, if you've been multiple places for care, you've signed a consent document everywhere you've been. What if you wanted to change one of those? You'd have to get in your car and drive all those places and change another piece of paper in those places. We need to centralize consent as part of this as well. So this is just an example of what a provider might see. So a patient comes to see me, and I pull up their record, and I can see where they've been. I don't know if this laser works or not on that screen. It doesn't. Upper left, I can see where they've been for care. I can see all the problems or diagnoses they've got, their medications, their allergies, their vital signs, from wherever they receive care, right? So that I don't make a mistake in prescribing something they're allergic to or they've already been on that's been tried. And we know that this improves the quality of services and care that's delivered. It also avoids duplication of test ordering expensive MRIs and CTs and so on. So this is MyHealth. As I said, it's a nonprofit based here in Oklahoma. As far as I know, it's the only nonprofit health information exchange in the state. And it's big. It's more than 1,000 locations now, more than 45,000 patients a day served by this system. Most every I'm going to say about 3.5 million people in the Master Person Index. I haven't looked today, but that's most of the folks here in Oklahoma. And as you can see by the different shapes on the chart, it's not just hospitals and clinics. We're talking about pharmacies, long-term care, hospice. If it's relevant to health and well-being, we believe it needs to be connected to this in order for patients and individuals and families to get the services they need. It's a lot of the named organizations you would know that created this. Essentially, the state did not move forward with creating this thing. Some states created their own version of this as part of state agencies. Our state did not, and so the private sector came to the table and said, let's build this. And as you can see, the Healthcare Authority, the Health Department, and HHS, Human Services, are all three involved as partners in this as well, just not owners of it. So the private sector built this. You can also see the tribes are engaged in this as well. And so it's achieved a pretty broad adoption and participation by emanating as a public-private project. So we have this other problem, though, right? Oklahoma's not all of the health care, and what this map shows is everybody who's received, the home address of everybody who's received health care in Oklahoma in the last 5 years, right? Who knew we had such a medical tourism going on to Oklahoma? We're giving MD Anderson and the Mayo a run for their money, right? Actually, every state looks like this. And the fact is, students come through, people traveling on I-40, and the fact of the matter is, if you care enough to go to the hospital while you're on vacation or while you're traveling, that data is important. And that data needs to get back home to where you live, right? So we're a part of a network that we actually founded. There's a group called the Strategic Health Information Exchange Collaborative that are other organizations like MyHealth around the country that have come into existence over the last 20 years. And you can see there are quite a number of them. And we helped develop a network called the Patient-Centered Data Home that connects all of those together. So if you were in banking in the 1960s, you would have started to see maps like this coming together for banking transactions. So we're able to securely move healthcare records from one community to another, in part because each state has its own privacy laws. So we can't just have one system. So when data comes to Oklahoma, say one of my patients that's admitted into a hospital in Arkansas, that data comes within about a minute of the hospital admission. So it's very timely, and it now is subject to Oklahoma laws and the policies local to our use, which helps deal with that issue of varying privacy laws. So this network serves about 200 million people nationwide, and last year we did 11 billion transactions. That's almost 100 times as many as the EHR vendors have exchanged among themselves. So another important concept to understand about this is kind of coming back to where I started, which is to have a value-based payment model, to start paying for value in healthcare, you have to be able to measure stuff, right? And if you wanted to, let's say, to buy a car, how many of you would just go to Toyota's website and read about the new Toyota and choose a Toyota? Nobody would do that. You would read Edmunds.com or AutoTrader or some review that's independent and read about several vehicles, right? You need to have somebody in the middle doing the measurement. You can't have either the payer for the service or the provider for the service measuring it, right? Well, in healthcare today, usually the insurance plan gets to do the measurement because they have the claims data, right? And providers don't like that very much because it doesn't have the nuances of the clinical results in it that really are important to knowing whether I delivered high quality care or not. Well, the tables have been turned a little bit now that we have the clinical data in electronic health record systems. Now the providers can measure and report their quality as well. But once again, the providers get to be the sole judge of that, and they tell the payers how they did. And so here we've got a contract situation where one party gets to do the measurement and the other one just has to accept it. And that's not a productive way to move forward in almost any industry. And so in healthcare, we've now got, fortunately, a third party that sits in the middle that is governed by both or all sides of the contract. And the measurement can happen there in a way based on the full data set, the claims and the clinical information, and have the identities normalized. And the blood pressure control reported can be used not just to judge the quality of care delivered by a doctor or a clinic or a health system, but also to know whether our public health is improving or not, or one county or another county needs more services than another. All right, so this elevates the data to a level where we can use the measured results for a lot of things. So we can measure things based only on claims, measures based only on clinical data. And at the end of the day, what we've really accomplished in Oklahoma that really honestly is the envy of the rest of the country is we've got a health information exchange that moves clinical data, but we've also got a voluntary all-payer claims database, right? So in many states, the legislature has created and funded an all-payer claims database. You don't have to do that. The payers fund the all-payer claims database here in Oklahoma, and it's voluntary for them to participate in. So we have most of the claims data in Oklahoma already aggregated and available for reporting by having that voluntary all-payer claims database. So just to make it kind of concrete, these are performance measures that we calculate, and you see the colored lines there indicate what deciles of performance whatever this is, practice or hospital or doctor performing in. You can see breast cancer screening, controlling high blood pressure, diabetes control, and so on. And that shows the performance, but we're also able to say, if I want to hit the 90th percentile, tell me how many more mammograms do we need to do to get to the 90th percentile. So it very clearly says this practice needs 748 more mammograms to be done. Well, now I'd like to know who are the patients that need those 748 more mammograms, right? And if I click on that link now, I'm shown the names. This is de-identified, of course, but I'm shown the names of people who need those mammograms or those blood pressure tests or those colonoscopies or whatever it is that we're trying to improve on. And this kind of infrastructure does exist within individual clinics and hospitals and their electronic health record systems, but it's never existed at a whole community level. And it's only at that community level that all the data is included in the story, and that the rural providers and independent providers and behavioral health agencies and social service agencies that don't have millions of dollars to spend on technology can actually access, engage, and participate in, right? And then, of course, we can trend, are you going to hit your targets or not on your quality measures? So one of the important points here is not just providing a way for, say, Medicaid, the healthcare authority, or any other payer or employer to measure the quality they're getting, but also provide a way for the physicians and hospitals to be successful, to know that they're getting there. If I don't know what's going to be on the test, I can't study for it very well, and I can't perform very well. So this makes that data available on a timely, daily basis to do that work. So I mentioned earlier the importance of protecting patient information, and this kind of work is obviously very sensitive. So the first 3 years almost of the existence of MyHealth, this nonprofit, were spent getting governance right, figuring out who gets to have a vote in deciding how this data can be used. And the three perspectives on the screen are the ones that seem to make the most sense and have therefore constituted the board. Those who pay for the services, those who deliver them, and of course, those who receive them, right? So that when decisions about, are we going to do this kind of report or that kind of report, or are we going to admit a new clinic or hospital to the network, those decisions are made by all of the three perspectives that matter most in health and quality of life. And so here's the board, what governs this kind of a network. And what I'll point out there is that almost every entity has a competitor there. So there's no one insurance company or no one tribe or no one school that can run away with the control. And in addition, it's got individuals and patients and the safety net and both OU and OSU who train medical students and so on in governance, as well as public health in the state. So it's pretty broad and it's kind of a big board, but we say this work happens at the speed of trust, and trust happens when you have some control. So it's a big board for a reason, and it functions very well. So, if this is critical infrastructure, if we agree that that's true, how does it get funded? Well, the average health information exchange on that map with all the dots that I showed you has received $7.5 million, runs about $7.5 million a year to operate. Our nonprofit runs about $4 to $4.5 million, so we're underfunded and understaffed in that regard. But part of the reason is because, unlike most of the others, we've never taken federal funding as a state to support this infrastructure. There's some massive programs that have funded this infrastructure to the tune of upwards of $80 million per state to build out these components and technologies, and as sustaining funds, as I'll show you in a little bit, to keep that going. So we've got to get in front of that, and I think things are in motion to do that. There should be an RFP on the street before too long about health information, having a health information exchange for the state that will hopefully begin to unlock those federal funds. So the good news is that there are federal funds out there. There's the high-tech program, which has both technology implementation at a 90-10 match. So we put up $1, we have $10 to work with, right? And sustainability program for that technology that's a 75-25 match. So, and that, of course, runs through Medicaid. There's something called the Support Act, which has been out there since last fall, that we've got to get on top of, and that's for structure to address opioid abuse. And that's a $0 match. All we have to do is put in a proposal, and we get the money. 20, 30, 50 million, whatever it is we ask for. If they approve our proposal, we get the funds. And the infrastructure we already have is prime suited for us to be successful in those proposals. And now under the Social Security Act, and for years now, but rarely used, even the Human Services can tap into 90-10 funds for building out this kind of information infrastructure to support improvement. So, but we have to hurry, because as you can see, the expiration date on the first one for implementation is in 2021. We're down to just months to take advantage of these funds. We've got to get moving. So let me just tell you quickly about 3 case studies. The first is value-based payment model, something called the Comprehensive Primary Care Initiative. Has anybody heard about that model? So when the Affordable Care Act was passed, something called CMMI, the Center for Medicaid and Medicare Innovation, was created. And they were tasked with testing new payment models. And one of the models they tested was called the Comprehensive Primary Care Initiative. And they picked 7 regions in the country based on regions that had multiple insurers that had already partnered together in a project. And so we had Blue Cross, Community Care, and Medicaid in Oklahoma that were already participating in MyHealth. And we were able to bring them to Medicare, and in exchange for their participation, Medicare invested heavily in our community to the tune of $100 million in new care management fees directly to the most vulnerable part of our healthcare delivery system, that is the primary care base. They invested in the primary care base. And it was just 68 practices, about 265 doctors, but because multiple insurance companies and plans were involved, it was about 90% of the patients in the practice. And so we were able to, the doctors in this program were able to focus on doing one set of activities and one set of measures across all their patients, which made a big difference because, I'll give you the punchline here, as you can see, $65 million were saved just on Medicare's 50,000 patients. Primary care in Oklahoma received $110 million in new investment, and Oklahoma, for the first time in my lifetime, was #1 in something positive in healthcare, meaning 95% of all the savings and most of the quality improvement happened right here in Oklahoma in this model, which shows that if we invest in our infrastructure and we have that ready to go, we can actually perform in these innovative payment models and do a good job. So we're now in CPC Plus, which is expanded statewide. It's not just Northeast Oklahoma now, and we're watching to see the results of that model. Second case study, evidence for policymaking. I know that you guys often need something for a bill. You need to decide which way do I vote on this thing, or even at this point, what should I write as legislation? What are we needing? And you need information from the various agencies, but you also probably could use information from the private sector if you had it. Health information exchanges enable this evidence-based policymaking by providing real-time reporting on things like disease burden, workforce status, where do we have doctors, where do we not have doctors, where do we have nurses, where do we not have nurses, outbreaks and epidemics. The data that flows to this health information exchange is about a minute old when it gets there. That's just in time for monitoring for sudden events. Trauma and disaster response. Every time there's a hurricane along the Gulf Coast, organizations like mine get on a call every morning where we check in to see where are people being evacuated to, and if we move their medical records to stage them so that they can get the care they need when they arrive at the evacuation point. Obviously, as a state with now multiple disasters, natural disasters that can occur, I moved home from California to quite a surprise on the earthquake front, and we need this critical infrastructure for disasters. And then, of course, opioid prescribing. We alone have the big picture on what's being prescribed. The Prescription Drug Monitoring Program knows what's being dispensed, but we know what's being prescribed in our data. And by the way, we have the only universal source of data on non-fatal overdoses. The ME only knows about fatal overdoses. So these are important pieces of information that we think you would like to know for policymaking. This enables, obviously, better laws and policy, measurement of impact of a new policy. I think this one and done, okay, we passed a bill, it should be the silver bullet that fixes everything, is foolishness. We should gird ourselves for a 10-year program of iterative improvement and change to make healthcare improved. And then the final case study I'll tell you about is one that just happened a couple weeks ago, actually. My academic department runs a program called the Health Access Network for Medicare, for the Medicaid agency here. And we provide care management services to about 150,000 Medicaid patients here in Oklahoma. That program routinely returns a significant return on investment from, say, $20 to $40 PMPM in savings for the folks in that program. But it's the individuals that get service that I think make the most difference. And what you see here is a story, a 13-year-old girl. She was a Medicaid patient. She was a high-cost patient. She had many different doctors, many different hospitalizations, and she was referred to our Health Access Network for care management services. And so the first time somebody was interested in the big picture and not just the little pieces of the story that occurred in individual hospitals and clinics and so on. And the care managers at the Health Access Network were able to log into MyHealth and see that this poor girl had 25 different doctors, had been to 8 different hospitals, and there was no clear communication among them that they were coordinating what was going on. And this patient was set up for a life-changing major surgery that would have fused part of her back, reduced her mobility for the rest of her life, and given outcomes, could have had infection and even death from the procedure. Fortunately, these care managers, not physicians necessarily, not somebody with more training than say social work, nursing, and so on, put the whole picture together because they had the data, and they were able to realize that this is something called Munchausen's by proxy, which is a mom or a parent, in this case a mom, who was basically directing their child in to get these services for their own attention seeking, and almost killed her child. So this is the kind of thing that we need information to move forward. It's why we need health information exchange. It's why we need it to be nonprofit and public-private sector partnership. And then I would say that the next frontier to tee up the rest of your day is that now we're working with social needs and early childhood programming information to make sure that the whole picture doesn't just include the parts we think of as health care, but health and well-being as well. Right? Is this child getting access to reading and services early enough, for example? And so, remember my picture about healthcare data? Well, social services and education data looks like this, right? It's government, it's philanthropy. If somebody needs a food pantry, they probably also need other services. And we have to build the infrastructure to tie these together. Now, most of these services are delivered in the private sector, believe it or not, but most of them are funded by government or philanthropy. And so we've already begun the work on the policy side to tie together HIPAA, which is healthcare, FERPA, which is education, right, and what we call fondly NOPA, which means there's no policy around privacy protection, so that we can bring everything under one policy umbrella to do this. My colleague will be presenting to you this afternoon on a social needs project we're doing, and I hope you guys will have lots of good questions for her about that project. And with that, I will stop.
Thank you, Dr. Kendrick. Members, do you have questions? If so, let me know. Senator Hicks, you're recognized.
Thank you, Mr. Chair. I was interested in the data that was presented on the board structure. It kind of alluded to regional health systems, having 3 and health systems with 6. Specifically, around, what we're seeing with mergers and acquisitions with health insurance companies, health systems, PBMs. Are there checks and balances there? Because obviously, the pie chart showed that it was a very diverse system, but are there checks and balances as far as, if mergers and acquisitions occur, are those being reflected in the board makeup?
That's a great question. And yes, that's one of the most important functions. I'd say a third of the effort in this entity is to manage the governance. So there's a governance committee that carefully looks at representation. Now, understanding that this entity has never received state money before to do its work, invitations have been given to state agencies to have an actual seat on the board, but they didn't feel like they could take them at that time. But that's certainly something that is on the offing. The governance structure has to be fluid for the reasons you just described. The definitions of the seats are based on, I'll say, an outcome basis, like the 2 largest commercial insurers in Oklahoma, whatever they are, right? The health systems or hospitals appointed by another organization, like the Hospital Association or the Tulsa Hospital Council. The tribes, they choose which 2 get on there, because we're not going to get in the middle of that. The 2 academic positions are the medical schools that train physicians, nurses, and so on. But it's also a big board, and so for reasons of, and it has to function, right? We can't have a day arrive when somebody can't log in and view a chart simply because a board seat was in contention. And so, like a private sector organization, board seats are negotiated and determined, and if there's a major hole in the network, say a big health system or a big insurer, then that's a part of the negotiation around this. But everybody on that board has a lot at stake, a lot at stake. There are multi-billion-dollar organizations on that board, and they pay attention to it. One of the most fascinating things to me about it is that we have a privacy and security committee that's basically all the compliance officers and privacy officers from the hospitals, the clinics, the insurance plans, the universities, and tribes around one table. I got to think that's the best aggregation of know-how around privacy and security in the country, possibly. And they meet once a month, right as rain, and they tackle big issues. And they would be great to advise you guys on policy as well, because they do a phenomenal job of reviewing things, and they'll, they don't just accept organizations to membership. They've got to prove their bona fides. They've got to be licensed. They've got to have no history of issues with either Medicare or any other federal contracting. They've got to be in good standing with payers. They've got to be in good standing with other providers in the state. So we think it's shown itself to be very functional governance.
Representative Ranson.
Thank you, Mr. Chair. Back on the slide that talked about federal funding, where there was mentioned that we are not getting federal funding, and there is a deadline, you said, of 2021.
That guy.
What do we need to do by that deadline to get access to those funds? Is that a Medicaid expansion, or is that something else?
Unfortunately, that deadline is the last day you can spend any of that money, not just apply for it. So every day that goes by is worth $100,000 or $200,000 to us, because you have to be able to, with federal money, you've got to be able to deliver the project, deliver the goods to draw down the funds. So our ability to execute is shrinking over time. This is separate from the Affordable Care Act and Medicaid expansion. These funds have been out there since 2010 as part of remember the stimulus bill in 2009 that created meaningful use? They're part of the component of that called HITECH. This is a program which I think hopefully we're positioning ourselves to take advantage of now. We've got 26 months left, something like that. Fortunately, we're pretty shovel ready as a state. I mean, most organizations that started taking this money in 2010 spent maybe 3 or 4 years getting the governance right. But we've got governance, we've got policy, we've got information actively being exchanged. We just need to connect a lot of little practices and clinics and rural communities that didn't have the resources to get connected in the beginning.
Senator McCortney.
Thank you, Mr. Chair. And somewhat to follow up on that, I have so many questions. But, so that money, and I think you just answered it, but I want to restate it to make sure that I understand. That is, did you say 9-to-1 matching
right.
funds? And that money can be used to help small practices, generally that would be rural Oklahoma, some suburban probably, foot the bill for this technology infrastructure. Is that?
That's right, and it's not limited to healthcare. The Medicaid director's letters over the last few years, as they've wanted to get the money out the door because some states were slow to draw it down, they've expanded the ways you can use it. You can use it for connecting anything in healthcare to anything in healthcare, but now you can also connect human services, social services to this. You can connect. It can be used to bring on correctional systems, right? Because we know the transition from incarceration to community is a revolving door if you don't get health care and social services engaged at that point. It can also be used to connect education. Imagine if we had school nursing effectively, even if it's virtual again. Imagine if we had the ability to detect early depression and social needs from the schools and not wait until they show up in a clinic or emergency room. So all of that is potential for a place that we could focus these 90/10 funds.
Follow up.
So what do you need from the legislature to make that happen?
Well, I believe there's some things in motion now. As I said, MyHealth is a private nonprofit in the community. So there is an RFP we understand that will be hitting the street in the next few weeks or months, or hopefully not too much longer. As I say, every day is a few $100,000 lost, that can be responded to, and organizations probably from around the country will respond to it. Certainly MyHealth will. No way to know what it's asking for, but hopefully it's asking for something that's local and already in place. Then the state will choose, OMES will choose a vendor to be the health information exchange for the state. And at that point, probably not until January 1st, will funds be able to be drawn down. Prior to that, I don't know if it actually requires legislative action or not, but the 10% needs to be identified for the first tranche. Now, you can pull down multiple tranches. I would say, given the short window, we don't want to have to go back as a state and make multiple applications. We want to put one in that's big, and they've approved, I think they approved $50 million for North Dakota or South Dakota or something. So there's the ability to get a big approval, and then you only get to draw down what you can execute on from that. But that cuts out paperwork and lets us just focus on the work.
Follow up.
Thank you. So this RFP that's coming out, and I appreciate, by the way, the tap dance that you're doing, knowing that you are a private vendor, and we asked you to come in and testify as an expert, but at the same time, it's, I know, awkward at times knowing that you're not here to sell your company, but at the same time, the only thing you can do is talk about your experience. So, so I appreciate the tap dance that you try to do there. So Oklahoma now, through OMES, is driving towards having one HIE that connects all of, because right now we're fragmented, is that correct?
Yes, there's fragmentation across many of the different organizations I talked about. There's quite a bit of connectivity on the private sector side, but it's not nearly as engaged with state agencies and state efforts as it could or should be, at least in my opinion. And, you know, it's always going to be the billion-dollar organizations that can do these things and not the clinics and hospitals in your own communities. So.
Follow up.
So back to the example you gave of the young patient on Medicaid, Healthcare Authority was here, I think it was week 1 of our meetings, and talked about kind of some of the ways that they were managing. I think they were talking about the medical home model that they work through. So that patient that you spoke of could actually have gone to a different set of hospitals in the state of Oklahoma, and we wouldn't have that information. Is that correct? Or?
There are some that are not connected yet.
Okay, so it's possible that the numbers you gave were just hospitals that are.
I think we, just to put a number to it, we're about 68 to 70% of all the what are called adjusted patient days, hospital activity, is what's covered now.
And that's what this RFP from OMES is hoping to get that as close to 100% as we can. Is that a fair
That's true,
statement?
and my hope is that it also contains some movement forward. Most of the time, the funds, as I said, I mean, most states went for these funds in 2010 and 11 to start with, and they had a long runway to build policy and governance and so on. That work's been done, so we have an opportunity to add bells and whistles. Like, how would you like, as a patient, if you could get your one medical record from everywhere in one place, right? How would employers like it if they could have some quality measures on their employee population? How would, you know, that's the reason I mentioned connecting things like schools and corrections and other things, because those are not even in the realm of discussion unless funds like this materialize.
Senator Stanislawski.
Thank you, Mr. Chair. You had spoken a little bit about privacy and security, and so I just have a couple of quick questions on that. So, number one, I think it was just several months ago, a hospital in California got all their records locked down with ransomware. What are you doing to prevent that type of issue with the amount of hacks and ransomware going on out there? How are we protecting that data from those on the outside that would like to take advantage of that?
That's a great question. So I said a third of our effort is around governance. A third of our effort is around that issue, protecting the security of the information. We are hosted in what's called a high trust environment, which is an environment that typically organizations with a lot at risk are great guides as to how much risk management you ought to do. And so our largest insurers and agencies insist that we have that highest level of protection around our environments. We have a group of what are called white hat hackers who try all the time to hack into our environment. Our developers all and everybody in the organization is trained obviously in HIPAA, but also in security to a high degree, much more than any individual clinic or hospital. And this is one of the things I think that makes this kind of a middle layer critical, is it's almost impossible to imagine, you know, a medication, you know, a medical assistant in a clinic having as much security knowledge about phishing attacks and other things as somebody who can be in one central core and understand that data. And so the mistakes are often made at those endpoints. I'll tell you a story. In New York, one of our colleague organizations, they had an entire health system have a ransomware attack, lock down their medical records, and they wanted millions of dollars to get them unlocked. So what happened? They went to the Health Information Exchange, the group in our role, said, can you give us our records back? And they said, sure. So there was almost like a backup chart for the health system's data. And indeed, we know of several instances where a hospital or clinic would be down on their EHR, and they would go to their mobile devices and still be able to treat people because they had access to the records in MyHealth.
Okay. Well,
Follow up.
thank you. So now let's bring it down another level. So you have many different entities as a part of the HIE. You have someone at some clinic who has access to the HIE who just would like to find out about their neighbor's health information.
Right.
She really, or he really, doesn't have a need to know.
Right?
So how do you prevent access from someone who doesn't have a need to know, yet are a part of the overall HIE?
So I'll answer that starting with the end point as well, the level where the MA or whoever that employee is works. That organization has a responsibility for detecting those things and preventing that access. And indeed, we've been notified by several organizations in MyHealth over time, hey, this is a rogue user, they've used the system inappropriately, we need to shut that off. The problem is that clinic only has visibility to what it has visibility to in terms of utilization. Part of the importance of this middle layer is we can monitor rapid access to charts by one individual or even multiple individuals over time. So, you know, if Russell Westbrook's chart got looked up a whole bunch, we flag those, and then we get in touch with the organizations that have those users and let them know they've got a rogue user. But without this layer, there's no way to know across organizations whether your records are being accessed. In fact, I'm sorry, I just want to just put a fine point on that. We have had patients call us and say, hey, my records were shared and I'm unhappy about that. And we said, okay, well, let's look. And sure enough, they had opted out, done everything right, so their records could not be viewed by anybody, including us. And we said, your records were not shared, but you need to check, because what happens now in this space is that the EHR vendors send data to one another. So if you're on a particular system like Epic or Cerner, the data moves from one Epic instance to another Epic instance, and it's not necessarily transparent or visible to the patient. And this is something that's occurring more and more often, and those patients love what we're doing because we can give them an audit log all the time about their work. I mean, about where their care is happening and their data is moving.
Follow up. And members, if you don't know what an EHR is, it's electronic health records.
Sorry, EHR, electronic health records.
Thank you, Mr. Chair. So let's go one more step, exactly what you're saying there. So in the credit world, if I want to look at my credit records on one of the 3 major credit agencies and run a report, it will tell me who has accessed my records.
Right.
Okay. As a patient, if I opt in, because I love the concept, I think it does fantastic stuff, but if I choose to opt in, at any point in time, can I contact the HIE and make a request who has accessed my records in the last year or 2 years, whatever that might be?
Yes, you absolutely can do that, and we can verify that the records are there. The current policy says that we point you to the organizations that did those lookups for them to tell you exactly who and when, because it's a membership organization. We don't want to trump their role in this. But absolutely, those records are tracked on every click.
Representative Fugate, you're recognized.
Thank you, Mr. Chair. As an old technology guy, I'm really excited to hear the things that are going on. I've worked a number of projects over the years dealing with health information, and so it's nice to know that data is being utilized on the other side of things. What I think I heard, if I could characterize what you were saying, is that the majority of our data across this state is already contained in the Health Information Exchange in one form or fashion. You mentioned at one point maybe 3 million people are kind of tracked through the system. And you alluded to the fact that in many respects we are really leading the nation in what we're doing with this. So connect this back now to the problem we've got. Why do we have such poor health outcomes in the state of Oklahoma?
That is a big question. Well, we have poor health outcomes because of years of neglecting the system and not tuning the system to get ahead of things, and it begins all the way back in education. How are we educating people about accessing health care, managing their health? How do we detect behavioral health issues early on? Depression. I mean, with the rise now of mobile devices in every kid's hands, we're seeing depression go through the roof among these kids. And, you know, one of the things we always say in the engineering side of my life is you can't fix what you can't measure. And we've never had a way to measure it. We've never had a way to really tactfully and specifically measure what the situation is in a given county, zip code, neighborhood address, and identify what intervention is needed there. And that's why I wanted to make sure and include the evidence-based policymaking discussion, because if you can measure it, then you can come up with ideas to fix it and address it. And usually they're pretty obvious once you've measured it.
Follow-up.
Thank you, Mr. Chair, and that kind of leads me to my second question, and that is the data that we have so far really just measures interactions with the healthcare system, and you're trying to pull together additional sources of data to help build a fuller picture of that, which I think is a fabulous idea. Is that a correct statement?
Yes. It's absolutely true.
Leader David.
Thank you, Mr. Chairman. Dr. Kendrick, thank you so much for coming today and presenting to us about this. I have a couple of questions I just want to clarify on the health information exchange. So how many other states do have a type of system like this?
Well, there are 77 other health information exchanges. Obviously, California has 4 or 5 of them, so I'm going to say it's all but about 2 states, maybe 3, have something on the spectrum of this level of work. Most not as aggressive as us or as capable as us.
Okay. And how many years have we been doing, have we had this one up and going?
2009 is when the work began. June 8th of 2009 was the first meeting.
Okay, and it sounded like you guys are not just involved in health information exchange. You also brought up case management, social determinants.
So I always say that we're the data, and we coordinate the data where it needs to go. And this was an important component of the early discussions of governance in MyHealth, which is MyHealth's role is not to deliver care or services, but it's to enable others to deliver them better. You've heard those conversations, those commercials by BASF or whatever. We don't make the products, we make them better, right? And so we also are in a position that we're not there to help one provider organization over another win. What they do, how they use the information and the data is how they differentiate themselves in quality and so on. So the boots on the ground piece I was talking about, the care manager, that's in my academic department at the university that does care management. It's a separate thing from MyHealth altogether.
Okay, well, I'm sorry. I keep forgetting to come back to you, Mr. Chairman. Please forgive me.
Follow-up. Absolutely, Leader.
Follow up, please. So the case management part and the social determinant part, that's all separate. That's just, those are vendors that use the information that are part of your board?
Yeah, so the humans with heartbeats that do something with the data are separate from MyHealth. The data itself, including the social determinants data, is in MyHealth.
Okay.
Follow-up.
One more question. So how are you guys licensed? What are you licensed as?
MyHealth. So MyHealth is a nonprofit 501c3, and it's under a business associate agreement with all its participants, just like any other software entity.
Follow-up.
Just for clarification, so MyHealth is not licensed as an insurer or anything like that. You guys
No.
are solely just an information place.
That's right.
Thank you.
Just information movement.
Dr. Kendrick, how many HIEs do we have in Oklahoma?
Well, we know of one nonprofit, and there is a for-profit HIE working among a few hospitals in southwest Oklahoma.
Do those two systems, from my experience and knowing, I think the health department has been trying to create some kind of a bridge for these two HIEs so they could actually take the data from both and combine them. All of that's been unfruitful to this point. So it goes to your point about how fragmented the data is. And you talked about, in context of a value-based system, how that fragmentation, basically, as a state, I'm going to ask you kind of a tough question here. Have we been able to really measure anything as far, apart from the private healthcare systems that have the money to do this, have we as a state been able to really quantify what's going on in our health system?
So let me tackle the first part of that first. So like any other industry, there's a sort of a narrative arc to the history of health information exchange in Oklahoma. And when MyHealth started in 2009, there was one in existence called SmartNet that operated out of Oklahoma City mainly, but was governed out of Tahlequah, interestingly enough. And in 2012, MyHealth and SmartNet were both competing for, I guess we were meeting at Stroud. And the governance of SmartNet said, this is more like, the power grid or the water supply. Why would we compete with each other when we could just be exchanging the data? So SmartNet decided to become a part of MyHealth, if that makes sense. And the board was divided, and the governance policies were set up to accommodate both groups. Somebody was not happy with that, and that created a new health information exchange in Oklahoma City. That lasted about 15 or 16 months, and they decided that they too would just become a part of the nonprofit health information exchange, and the residual of that became a private company that's now owned in Texas, I think. So it evolves over time, but the major point I would make from that is this is like the highway system. I don't know, we shouldn't compete on this. This is infrastructure. And most states that I look up to, like Arizona, Ohio, Indiana, and others, have early on realized, Michigan, realized that this is infrastructure and we should just pick one and go. My career is not to run a health information exchange. I'm an academic faculty member. I'm here to do research and design and build new things. I'm running this until it can become infrastructure. So your next question is, can we measure anything? So for the 70% of the hospital activity we do have, yes. For the 100% of claims data we have from Medicaid, from the commercial insurers, and the 120,000 lives we have from Medicare, yes, we can and do measure. Are mammograms happening? What are blood pressure rates like? Is diabetes under control? We have the ability to report those things, say, to the state health department, and in fact offered to do that for a project they had with the CDC, but ultimately they got wrapped around the axle needing to do a full RFP process or something to access this data. I'm very hopeful that the next step forward, by having an RFP and identifying a vendor, that the state will be able to engage more freely and make use of these assets.
Senator Quinn.
Thank you, Mr. Chairman. You showed a slide early on in the presentation about life expectancy. Mm-hmm. And I want to use that as an example. I'm not saying that it's true or untrue, but when you have the millions of dollars that are being chased that revolve around Medicaid or health care expansion, how do we go about trusting the data and the information that is associated with this? The reason for that is when you put out hundreds of millions of dollars, and then you throw in a political aspect of it, how is the average citizen or legislator supposed to find consistent ways of trusting that data and information? Because on that slide, and I couldn't tell all the names on it, but I know that the U.S. is supposed to have a lot better reporting system than many countries in the world. So if someone's not reporting infant mortality rate to the detail that the U.S. is, then it's going to make the U.S. look like that they have higher death rates. And that's just one, to me, a simple example of how it can be skewed, is
manipulated.
Somebody said, make it look like something because the motivation behind it is dollars or the motivation behind it is political. How do we go about working through the weeds on that?
I hadn't expected so many philosophical questions, but this is a great one because ultimately what we've built is a philosophical construct.
Could you say that again about
I said I hadn't expected so many philosophical questions. Oh. So this is great because this really gets to the heart of the matter, right? We say governance is the key asset. Governance and trust are the asset this organization holds. I mean, the data is obviously an asset, but the trust is the most important thing. And maintaining trust means understanding things like conflict of interest. So those three circles that showed who governs, who makes decisions, those are organizations with a vested interest in the outcome, and they balance one another out. The provider tugs at the payer, tugs at the patient, tugs at the provider, right? And that balance is really important in the governance model so that no one entity can call all the shots and so that transparency is there. Everybody who's involved in governance in Miles has to make disclosures. You saw my first slide was my disclosure of my conflicts. We were very rigorous about that because everybody has a perspective. And it's very difficult to trust something whose perspective has not been made known to you before they're there. So if they're in the room selling you something, they need to be known. They need to know what they're selling. So we learned that very early on in the creation of MyHealth because we had won one small federal award, and you wouldn't believe the number of vendors that came out of the woodwork to sit around the room and opine on, well, we should build this or you should build that, and it just happened to be their own product that could do it. So attention to detail around conflicts of interest in governance is a critical component of making this work. That hopefully builds trust over time, but you saw this, the aspiration that this entity is a trusted third party in the middle, right? So, for example, I don't have a vote in the board. I'm there to serve as an executive as long as that board wants me, and then I go away when they don't want me anymore.
Okay, members, in efforts to stay on track, I'm going to shut down questioning, but if you want access to Dr. Kendrick, we can give you that contact information so you can ask him any questions. So we'll close this segment of the morning with Senator McCourtney.
So I have the last question, so I better make it a good one. I would like to, I guess, end maybe where we started, because it's really easy to get in the weeds on how this works and security and everything else. And you talked in here in the slides about a demonstration project. I never can remember what it was, but we were very successful with some primary care physicians driving outcomes, and it made them financially successful also. Mm-hmm. Can you tell us, I guess, what that project was, what outcomes they were driving, and what we learned from that? And then also, for those physicians, if I, in my memory, remember this story, it was very financially beneficial for them. It was great for their patients and great for them, which is really the win-win here. Can you go into a little more detail of exactly what that was and how that worked?
Sure. So this was the Comprehensive Primary Care Initiative. I've got the 4-year results on the screen there. Several important characteristics of the model. One, it was multi-payer. So Blue Cross, Community Care, Oklahoma Medicaid, and Medicare all partnered, which greatly simplified the number of messages coming to practices about how to do things differently, or, different pieces of paper to fill out and so on. So that was one win in this. The second is that each of those payers brought something to the table for upfront investment in infrastructure. Medicare brought about $20 per patient per month to fund a care manager. So for the first time, instead of just the person checking patients in, the nurse rooming patients, and the doctor, a clinic got to have a care manager with nursing credentials or social work credentials to focus on the patients who weren't in the waiting room, right? It's often the patients who don't show up that are in the most critical need. They're sitting at home with high blood pressure. They're sitting at home with an ulceration or something they're not getting dealt with. And so these care managers, Oklahoma, I think of that project as training wheels for value-based payment models, because it was initially an upside risk only model, so they could only gain more money if they were successful, but has now grown into a upside and downside risk. So for those practices who got good at this model, the first thing every practice did was change their answering machine so it no longer said, If it's Friday at after 5 p.m., go to the emergency room. They change it, say, if it's Friday after 5 p.m. or any other time after hours, I want you to call me. Because I can prescribe something over the phone or see you on a Saturday morning for way less than an $1,800 emergency room visit, right? And this comes to the essence of the model itself. It was a shared savings model, meaning the Medicare, and I'm only showing Medicare's results here because I don't have the private payers, but Medicare's model was they predicted what the spend was going to be on the population by extrapolating from past spend. All the way down to the individual level. And then they look to see if the practices wound up spending less in the total cost of care. So even though I'm a primary care doctor and I manage certain diseases and I don't do surgeries, I was accepting some responsibility or accountability for how much my patients use the hospital, the emergency room, which was really the first time that had been pushed down to the primary care doctor in a material way, and they rose to the challenge. They were able to change their processes and their workflows to make themselves more available and accessible to their patients. And they also started to use data to say, oh gosh, I've got 2,000 patients, but these are the 10 that go to the emergency room all the time. I'm going to get them on the phone. I've seen them go to the extent of scheduling a 30-minute phone call with a patient every week with their care manager to keep that patient from using the emergency room every week, right? So it turns out that healthcare is a very complex thing. And until you get down to the individual relationship level with a doctor and their patients, then you can't really affect much. And this model hit that nail right on the head because it aligned the incentives of the doctors who got, they couldn't save a lot of money in the practice. I mean, primary care is what, maybe 6-7% of the spend in healthcare in Oklahoma. It's 12% of the spend in Colorado. Incidentally, their numbers are way better than ours on every front. So that's a part of the equation here is figuring out how do we make more of the care happen in primary care settings. But by aligning, so I couldn't move a lot of money around as a primary care provider, but if I keep somebody at the emergency room, if I avoid a few hospitalizations, if I'm able to get people discharged earlier because I'm doing close follow-up, seeing them within 24 hours, those are all things that reduce cost from the healthcare delivery system, and frankly, they improve health and quality of life. So this model hit on a lot of cylinders, and at the end of the day, a lot of the primary care doctors took home a $200,000 bonus check. They did well by doing good.
Well, Dr. Kendrick, you've certainly given us lots of food for thought on how we can, provide better health, better care, and at a better cost, which is pretty much our aim of being here. So we appreciate that. Thank you for taking time out of your day to come and speak to us. We appreciate it as well. So right now we'll take a 10-minute break and let everybody stretch their legs and do whatever they have to do.
Thanks very much.
So we've got an hour for the American Cancer Society to give their presentation to us. We have Scott Tolan, and he has someone with him. So as you guys speak, and please introduce yourselves before you speak. You don't have to do it every time, but please introduce yourself before you speak. Thank you for coming today. We appreciate it. You're recognized.
Thank you, Chairman. Thank you, members of the committee. Thank you, co-chairs, for having us here today. I'm Scott Tolan, the Government Relations Director with the American Cancer Society Cancer Action Network. We are the advocacy affiliate of the American Cancer Society. I have with me here Kristen Kirkenbauer. She is the Tobacco Use Prevention Manager at OSDH. This is a lot of the hard data that we're asking about when it comes to tobacco use in Oklahoma. Quick note that this presentation includes recommendations from the American Cancer Society, Cancer Action Network, the American Heart Association, and the American Lung Associations to combat tobacco and vapor use in Oklahoma. We're going to go over tobacco control funding, go over the scope of the issue, and evidence-based strategies to address tobacco and vapor usage in Oklahoma. So let's start on a positive note, as I think it often gets tiring hearing about how negatively we are doing. We have done a great job at protecting the master settlement funds from the MSA funds from the trial in the late 90s. We have reinvested those funds to combat the negative health impacts of tobacco use. We are the only state to constitutionally protect those MSA funds in the nation in this way. We have one of the top helplines in the nation. In FY18, our state helpline, primarily funded by TSET, saw over 29,885 Oklahomans register for services. over 18,000 direct referrals from healthcare providers, with over 5,800 being from the electronic health record, which is timely considering our past presenter. We have had 2 tax increases, one in 2004. That is a 33-cent tax that went towards tobacco control with OSDH, and then we previously had our last tobacco tax was in 2018. That tax did not go towards tobacco control, so just want to point that out. We provide comprehensive cessation benefits through our state Medicaid agency. That was a partnership between OSDH and the Healthcare Authority, as well as TSET at the time, to identify and expand access to those cessation benefits, breaking down the barriers to folks getting cessation. We have an NCI designated facility, cancer facility at Stevenson Cancer. TSET plays a large role in that being designated. It provides a constant stream of funds for clinical trials and funding community programs. We do a great job of doing that. Supporting federal initiatives. So when HUD decided to make all of its housing authorities smoke-free, TSET, OSDH will work together collaboratively with them to make that happen. And in state legislation, we have the Tobacco Free Schools Act. So that's also a positive note to highlight. So let's move into tobacco control funding. So for FY18, the CDC has us at $19 million for tobacco control funding. This does not include state and federal dollars from OSDH. That number roughly comes to $2.1 million from the state in OSDH. So this $19 million for tobacco control is from TSET. So it is a fair statement to make that TSET is our comprehensive tobacco control program in Oklahoma. If we didn't have TSET, then we would not have comprehensive tobacco control in Oklahoma. So with that being said, point out that the total state spending is $21.3 million. Tobacco industry roughly spends $174.2 million in Oklahoma annually. That does not include funding for lobbyists. So when we talk about $21.3 million, this is the industry that we are up against when it comes to improving our health outcomes. Go ahead and pass it over to Kristen so she can speak on it.
I just wanted to say thank you for allowing me to speak today on Oklahoma's #1 preventable cause of death and disease, which is tobacco use. In Oklahoma, tobacco addiction and the harmful effects of secondhand smoke have plagued the state. So I'm going to give an overview of the burden of tobacco in Oklahoma, as well as the evidence base regarding research and strategies that have been proven to reduce rates among adults and then also prevent youth from initiating.
I know you've been introduced, but will you please introduce yourself?
Sure. Kristen Kirchenbauer. I'm from the Oklahoma State Department of Health. So currently 1 in 5 Oklahoma adults smoke cigarettes. We have higher rates than most of the nation. We're 12th in the nation in regards to the highest rates. We consistently have high rates. Among American Indians, they have the highest use rates compared to other racial groups. They're at about 29% compared to 20% for the state. Additionally, we have high rates of use for other tobacco products. This includes cigars and smokeless. We've seen a 50% reduction in cigar use since 2010. Amongst everyday smokers, it's below 10% and then just below 3% for cigar use overall. We also have high rates of smokeless tobacco use. We're at 7.4%. We've seen an increase over the last few years. So anytime we look at tobacco, we like to look at the data and categorize it and look at social determinants as well as high use among specific populations. We know certain groups of people use these products at greater rates and have different use patterns. So as you can see by this slide, those who have lower educational attainment typically smoke at a greater rate, low income also at a greater rate. The highest rates are among the 25 to 34 age category, and as I previously stated, American Indians use it at a greater rate at 29%. I also want to mention that certain groups, as I just previously stated, use at different rates. So, for instance, African Americans typically use menthol products at a greater rate than other racial groups. This has to do with advertising and marketing. Additionally, we know that the LGBTQ populations have higher rates. We don't have that number for Oklahoma for adults, but we do for youth. So of the high school students that identify as LGBTQ+, they smoke at a rate of 20%, when the rate for Oklahoma in general is 12.5. We also know individuals with mental health or substance use disorders use at a greater rate. According to the Oklahoma Department of Mental Health consumer data, those that have been diagnosed with mental health disorders, they smoke at a rate of 45%, and those with substance use disorders are at 51%. When we survey Medicare members, they're at 27% for smoking, and then about 30% for tobacco products. So this slide should be alarming to you. Currently, 1 in 8 youth smoke cigarettes. We're 5th in the nation for the rates for smoking. We've seen huge declines since 2003. A lot of that has to do with state policy work and community level work, as well as federal regulation. But this is concerning for us because we know that most youth begin smoking or using tobacco products before they leave their teens, and it's 96% for before the age of 26. So it's very important that we continue to watch smoking for youth. We have a new product that youth are using at a greater rate, even more so than smoking. It's e-cigarettes. Before I get into the burden, I wanted to just give a general overview of what e-cigarettes are. I'm sure most of you in the room have heard about e-cigarettes or seen them. They're on the media a lot. E-cigarettes are now the most commonly used tobacco product among youth. So basically what these are, it is an electronic device that allows the user to inhale aerosol, liquid nicotine, and other additives and flavorings. They're typically made up of components such as a mouthpiece, a cartridge that holds the liquid nicotine or the e-juice. There's also a heating element, and then something that charges that heating element, usually a lithium battery. The e-juice or the liquid comes in varying levels of concentration for nicotine and also different flavorings, which are very appealing to youth. The first generation on the left-hand side are what we call Cigalikes. These are disposable products. Essentially, once you're done with the product, you throw them away. The second are those vape pens. What makes these different, they're rechargeable, and they also have a cartridge which you fill your nicotine in that device. The thirds are the mods or tank systems. They call them this because you can modify it. If you have time or if you're interested, you can go on YouTube and look at the vape clouds that come out of that. So typically they'll modify these devices and the wattage or voltage to take in more of the product. And then the fourth generation, which we're really seeing insurgence of in Oklahoma and across the nation, are those pod mods. These are the ones that are coming about. We get calls from schools across the state asking what they can do about these specific products. The one on the left that looks like a USB port or USB drive, that is typically referred to as Juul. There are a lot of imitation products, but they're very easy to conceal, and the amount of emission that is put out from the user is very limited. You can't even see it. And the smell, it's hard to even identify the smell. It smells like a fragrance or lotion, so teachers and parents are having a hard time identifying when these products are being used. I do want to mention that the pods that are for the Juul products, one pod contains as much nicotine as a pack of cigarettes. They also use nicotine salts, which controls for the pH, so whenever it allows the user to take in more and it's less harsh on the throat. So addiction for youth, because it is so much easier to use, is a big concern. The one on the right, the Soren, this is becoming a new and emergent product, not only for nicotine, but the reason why these have appeal for youth is because you can change the nicotine, the solution that's used in the pod. So they're using with THC and other substances. Newest product that I wanted to mention are the heated products, or heat not burn. You might hear it referred to as that. These are different in the fact that they use real tobacco and not the liquid nicotine. So these just recently became available in the market in the US. They've been overseas. We've seen these products being used. So the idea is that it is more like a conventional cigarette, and it feels similar to using a cigarette, but the tobacco industry has said that it does not use combustion. The CDC was here last week, and they have concerns about, they're not convinced that it isn't actually doing some form of combustion. So hopefully as these are on the market, we'll get more information as time goes by. So in regards to the burden, I did want to point out that we have the highest e-cigarette rate among adults in the nation. So currently, 1 in 14 adults use these products. The social determinants are a little bit different for these products. You'll see that the income level is a little bit higher for use rates. Also, what's interesting is American Indians use these products at a greater rate than the other racial groups. I should also mention the age category. So these are very appealing to young adults. This is also another alarming slide for youth use in Oklahoma. So currently we were 11th in the nation, 1 in 6 use these products. As we see, I'll go on to the next one, these are the most commonly used tobacco product among youth in Oklahoma. In 2018, in December, the Surgeon General put out a public health advisory noting that youth among youth for e-cigarettes is now an epidemic. We're experiencing that in Oklahoma as well. So essentially, I want to make one distinguishment. A lot of times we'll hear that these products might be used as a cessation aid for adults, or it's harm reduction for adults. I want to be very clear that there might be harm reduction benefits for adults. We don't know what the science says. Currently, they're not regulated as cessation aids, but there might be some harm reduction if they completely switch and use just e-cigarettes. But in regards to youth, we know that there is no safe level of nicotine. It harms the adolescent brain and brain development, cognition, memory, as well as a greater propensity for dependence on not only tobacco, but other substances. Common reasons why youth use these products: flavoring, low perception of harm, and curiosity. They do not use this as a cessation aid. Main concerns we have are the health concerns, so we don't know what the long-term health consequences will be for adults or for youth. These products with the liquid solution, they have what are called GRAS, or generally recognized as safe additives for consumption, but we don't know about inhalation. So there's major concerns on what the long-term impacts will be, and we also know social norms are an issue for youth. Advertising has a big play in how addiction works for kids. So Dr. King at the CDC uses a very good picture. So getting a horse to water. The advertisement gets them to the product. The flavoring allows them to try the product. And then the nicotine keeps them coming back. So social norms are a big issue for us if we want to address youth rates in Oklahoma. I included this map so you could see how we compare to the other states in regards to adult prevalence, and then also for smoking rates. You'll see that we're one of the top 5. Those states in the dark red have the highest rates of youth use for cigarettes in the nation. I wanted to include this because often we report on the Burfess numbers or the YRBS surveillance data, but another really good measure to use is consumption data from the Oklahoma Tax Commission. And so I wanted to highlight this because I think it really highlights the actual product that's being consumed as opposed to just surveillance data through survey. In 2009, the Oklahoma Health Improvement Plan, we had a baseline of 79 packs per person per year. We're down to 58 packs per person per year. So we have sold 59 million fewer packs of cigarettes since 2009. And that's a great success because of the tax increases, not only at the state level, but also the federal level and a lot of the community initiatives that we've worked on at the local level. There's a lot going on here. You don't need to look at the numbers, but I think this really highlights and shows when you increase the price, which is the purple line, consumption goes down. And this is not just for Oklahoma, this is nationally. You can see that there's a great inverse relationship between these 2 points. So in regards to the chronic conditions related to smoking, we know 1 in 5 deaths are attributed to smoking in Oklahoma annually. Of the 40,000 deaths, we know 7,943 are attributed to smoking. The 4 major chronic conditions that are one of the biggest factors for our mortality or health outcomes: cancer, cardiovascular disease, COPD, and then other diseases such as diabetes. We're 48th in the nation for cardiovascular disease, and 1 in 5 of those cardiovascular diseases, deaths, are attributed to smoking. We're 45th for cancer, 1 in 3 are related to smoking. And then COPD, which you would assume 8 out of the 10 are attributed to smoking. So what are the costs outside of the health? We have an economic burden as well. We spend $1.62 million in medical alone. Medicaid spends $264 million, and then we have $2.1 billion in loss because of productivity due to premature death. The average household spends about $828 on tobacco-related costs, regardless if they use the product or not. The tobacco industry spends $44, where we spend $5 for prevention. And those data, that comes from the Campaign for Tobacco-Free Kids. They estimate for all of the states. So I have comparisons for all. So now that I've told you all the horrors about tobacco use in Oklahoma, what can we do about it? What have we been doing for the last over 20 years in tobacco control? So we have a very robust evidence base and research that lets us know what strategies we can implement to not only reduce rates, but also prevent initiation for youth. The Surgeon General's report, the blueprint for the Institute of Medicine, basically outlined that we should implement a comprehensive tobacco control program if we want to see rates decline. This includes an evidence base that looks at social strategies, policy strategies, community interventions, and then clinical practices. Which that blue document is the clinical practice guidelines, which outlines how providers should treat tobacco dependence. And we use this anytime we work with health systems on tobacco cessation. So what does that look like? What are the components of a comprehensive tobacco control program? I wanted to give an overview of the components and currently just a snippet of what it looks like in Oklahoma and how we work together to achieve a comprehensive tobacco control program. So you need several components. You have to have state and community interventions, mass reach health communication interventions, administration and management, surveillance, evaluation, and cessation interventions. And so in order for us to have this plan, as Scott previously mentioned, we work in great partnership with the Tobacco Settlement Endowment Trust to ensure that we have all of these components. For example, state and community interventions. The health department funds 7 local Empower grantees. They focus on disparate populations. We fund 5 tribal nations, 1 organization that provides services for African Americans, 1 organization that provides services for Latinos. We have funded these for over 10 years, and they implement tobacco control at the local level. The Tobacco Settlement Endowment Trust, they fill the gaps for us because we don't have the funds to do community program grantees outside of those 7 Empower grantees, and they saturate the state with local level experts. As Scott previously mentioned, an example of how we use those experts are when federal policy or even state policy comes down the pike. For example, when HUD had all of the public housing authorities that were 100% funded by HUD go smoke-free. We, the health department, helped those PHAs that were interested and the community grantees as well to implement policies that would meet the requirements. But in some cases, those PHAs went above and beyond what was required by the federal government. Another example is when tobacco-free 24/7 schools policies went into place, or the law. Those grantees helped with policy implementation as well. The next is the mass reach health communication intervention. Counter-marketing is very important for tobacco control because you saw how much money they spend here. Currently, the health department does not have the funds to address the mass reach health communications. We rely on the Tobacco Settlement Endowment Trust to do this portion of the plan. We provide content or expertise if needed. I would like to also mention that the majority of the people that get to the helpline, when we ask how they heard about the helpline, it's usually typically through a media avenue. Typically TV is the largest one. There's also print, advertising, media. Those are the venues of how people get to the helpline. The next is cessation interventions. So as Scott previously stated, the TSET funds a majority of the funds for the helpline. We fund about $500,000 of the helpline. They also fund 3 grantees that work on health systems change to incorporate tobacco control, tobacco dependence best practices. That's the Department of Mental Health, the Healthcare Authority, and the Hospital Association. And so for the healthcare systems that are not covered by those grantees, the health department fills in the gaps. So that would be the county health department systems, community health centers or FQHCs, and then also IHS tribal facilities. We'll fill that gap and work with them. And as Scott previously stated, some of the fruits of the labor from this partnership have been over 18,000 direct referrals from providers through the EMR to get these folks help for treatment. And so we hang our hat on that. We've done a really good job. Surveillance and evaluation, that is our primary role as the state health department. We use data to help guide decisions, resource allocation, and interventions. We evaluate all of our programs internally, and we help partners throughout the state utilize data to help make decisions. The last part is administration and management. The state health department provides an oversight of this in regards to the state health plan or the state tobacco control plan that we put out every year. It's a mandate in Title 63 that we update this. This helps guide new and emerging evidence base, providing data to partners, and helping provide an evidence for Oklahoma of where we're at and where we need to go. Also, a key part of administration and management is you have to have people in order to make this work. And so that's how we also provide infrastructure for these projects. So with that, I'll hand it back over to Scott.
All right, we'll go ahead and move into recommendations for Oklahoma. So it is clear that Oklahoma is falling behind. Highest e-cigarette use among adults and high school students, one of 13 states without a strong or comprehensive clean indoor air law. Inadequate youth access laws. We are super preempted in Oklahoma. That is not by accident. Get into that later. And disparities. So when compared to other states, Oklahoma continues to fall behind. We continue to have some of the worst outcomes, as you just heard. One of the major contributing factors is tobacco use and exposure to secondhand smoke, and people are dying at greater rates in Oklahoma because their state has some of the highest rates of tobacco use and secondhand exposure. So we talked at the first healthcare working group about America's health rankings. So Paula Warlick with ACS Can is passing out a document. Us and our partners, we did a deep dive on the information that was presented there. I want to highlight some things for you. Examining just Oklahoma's border states with comprehensive smoke-free laws rank the highest. So Colorado at 8, Kansas at 27, New Mexico at 35. The states that rank the lowest all lack such laws. Texas at 37, Missouri at 38, Arkansas at 46. However, despite not having a statewide comprehensive smoke-free law, Texas and Missouri rank 10 spots higher than Oklahoma due to local municipalities possessing the ability to pass smoke-free laws and ordinances. Well, currently, Texas comprehensive smoke-free ordinances protect 12.5 million Texans, communities large and small. And over 50 Texas cities have passed comprehensive smoke-free ordinances that cover all indoor workplaces in their cities, including restaurants, bars, and non-hospitality workplaces. Oklahoma is just one of 13 that does not have a CIA or a clean indoor air law. Over 12% of Oklahomans report being exposed to secondhand smoke in the workplace within the last 7 days. And that should be unacceptable to us. With every breath in a restaurant or a bar that allows smoking, workers are exposed to 7,000 chemicals that cause heart disease, lung cancer, and other serious illnesses. Non-smoking employees smoke the equivalent of up to 36 cigarettes, almost 2 packs, over the course of an 8-hour work shift. So we should ensure that everyone is protected from harmful effects of secondhand smoke when they go to work. And over 60% of smokers report that they want to quit, and research has shown that smoke-free laws prompt more smokers to try to quit, increase the number of smokers successfully quitting, and reduce the number of cigarettes that continuing smokers consume, and discourage kids from ever starting to smoke. Even the tobacco industry knows that clean indoor air helps people quit. Philip Morris's own research found that prohibiting smoking in the workplace not only reduces consumption, but also increases quit rates. A 92 memo Summarizing these findings state total prohibition of smoking in the workplace strongly affects industry volume. Smokers facing these restrictions consume 11 to 15% less than average and quit at a rate that is 84% higher than average. That's the tobacco industry's own research when it comes to clean indoor air laws. So if you're a 3-pack-a-day smoker, you have to have a workplace that allows you a place to smoke. It doesn't help the smoker quit, and it exposes their coworkers to harmful secondhand smoke. And it's important to note at this point in time that separate ventilation does nothing to protect against the dangerous carcinogens found in secondhand smoke. In 2006, the U.S. Surgeon General released a report entitled The Health Consequences of Involuntary Exposure to Tobacco Smoke, and it concluded that it does not work. This was 3 years after Oklahoma included separate ventilation in our current state statutes around smoke-free. Moving into preemption, Oklahoma is super preempted for making local level changes regarding tobacco control efforts. Currently, local level governments cannot address free indoor air, youth access, advertising, or licensure. So my wife and I and our child, we live in Edmond. Edmond, Oklahoma is one of the first communities to propose a smoke-free ordinance. And it wasn't too long after that that the tobacco industry swooped in with their lobbyists and lobbied against that ordinance. This greatly impacts their ability to make policy changes that would impact use rates among youth and adults. The fact that Oklahoma is super preempted is not an accident or a simple coincidence. Oklahoma was and remains ground zero for the tobacco industry's tactics, including the implementation of preemption or weak state laws that tie the hands of municipalities from addressing how to improve their citizens' declining health status. Major U.S. cities throughout the U.S. have seen declines because of their ability to address this issue at the local level. And Oklahoma has relied heavily on voluntary policy implementation and support from local level advocates to move forward state level policy changes. This includes TSET. Both tactics bring about change, but the process is slower and the outcomes are seen at a slower rate. And repealing preemption would allow communities to make laws that would really make a difference in their communities, but also impact health outcomes. So we'll speak on youth access. Also, our sell rates to minors for tobacco products is 18.5% currently, which is one of the highest in the nation. And we know that youth that have never smoked before age 18, and especially before age 21, are significantly more likely to never smoke at all. And because nicotine is incredibly addictive, to really bring about the end of tobacco's health impacts on our state, we need to get our youth use numbers down, which means we need to make access more difficult. Numerous research studies have found that making obtaining cigarettes and tobacco products inconvenient, difficult, and expensive for kids reduces both the number of kids who try or regularly smoke cigarettes and the number of cigarettes consumed by kids who continue to smoke. And our current statutes are set up to punish youth, not to assist them. We know that penalties and fines on youth do not work. There's no evidence base that supports that. What does is evidence-based practices, such as raising the tobacco tax and strong indoor air laws. As Kristen highlighted earlier, flavoring and tobacco products make them more appealing to youth. We see that certainly with the e-cigarette epidemic. In 2014, 73% of high school students and 56% of middle school students who used tobacco products in the past 30 days reported using a flavored product during that time. Oklahoma could address flavoring as well when it comes to advertising at the local level. So when it comes to the number one policy that we could implement when it comes to tobacco use in Oklahoma, increasing the tobacco tax. There is no greater policy intervention that the legislature could address than raising the tobacco tax to curtail tobacco use. Beyond that, I've mentioned clean indoor air laws, preemption. We move into youth access, we've done that as well. Lastly, I'm going to speak on e-cigarettes as a general topic. The state needs to examine how e-cigarettes are regulated. Currently, e-cigarettes are not regulated like tobacco products in Oklahoma. Retailers are not required to have a license. This makes it increasingly difficult to even know how many retailers there are in Oklahoma, and the state should also require licenses to sell e-cigarettes and increase the licensing fee for selling tobacco products. The money could be allocated for increased enforcement, with ABLE and OSDH working towards creative solutions to help curtail this use. As Kristen stated, there's a rising youth e-cigarette epidemic, and Oklahoma is feeling the effects. The state receives calls from schools and parents from around the state asking for assistance and guidance on how to combat the use of e-cigarettes among their students. And if history has shown us anything, Oklahoma has continued to have higher tobacco use rates than other states, and we expect to see high rates of e-cigarette use among the youth. If we don't address it by using evidence-based strategies that have been proven to work. Tobacco is tobacco, and the industry's playbook remains the same. Addict youth to nicotine, and you have a customer for life. Kristen spoke about how much nicotine is in a jewel pod. That should be very concerning for everyone in this room. E-cigarettes, like conventional cigarettes, are simply a nicotine delivery device. Dr. Wagner, he's the former tobacco regulatory science director at the Oklahoma Tobacco Research Center, stated e-cigarettes are unlikely to be harmless and should not be considered to be part of a healthy lifestyle. And when considering updating Oklahoma's clean indoor air laws, adding vaping and the use of vaping products to the provisions would reduce exposure to secondhand or third-hand aerosol, as well as reduce the perception by youth and non-tobacco using adults that vaping is normal. I point out as well that there is a massive federal investigation into hundreds of sick kids being conducted by the CDC currently today. I would also like to point out, I can't think of a single product that is made for human consumption that is as unregulated as the vapor industry. We more closely monitor gas station hot dogs than we do the vapor industry. Speak for a moment on cessation. Additionally, other states focus on health system changes to incorporate treatment options within health systems to ensure all people are provided evidence-based treatment for tobacco dependence. This also includes working with health systems to refer to the state helpline. Quick note on the state helpline. So we have talked about who happens to pay for the state helpline. The state helpline costs $4 million to run annually. And so the state federal share is 2.1. Clearly they would not be able to operate that helpline if it weren't for additional funds from TSEP. Spoke briefly on the positive, what we have done when it comes to increasing access to cessation benefits through our Medicaid program. Obviously, any discussion about increased access to Medicaid would, expand those benefits further. Data demonstrates that more individuals are able to quit smoking thanks in part to Medicaid expansion. Ohio is a great example of that. Approximately 26,000 state residents were able to quit smoking after the state expanded its Medicaid program. Most Medicaid beneficiaries, particularly in the expansion population, receive coverage for the full range of cancer screenings and other preventative care to help prevent and detect cancers early, helping to both save lives and save state dollars on costly treatments for late-stage cancers. Individuals who qualify for Medicaid in states that have expanded their Medicaid programs receive full coverage of preventative services, and individuals who qualify for Medicaid due to some other category may not necessarily have access to all those preventative services today in Oklahoma. When we talk about counter-marketing, such as those provided by TCEP. This is an evidence-based practice. This is evidence-based practice that is used across multiple industries. This is not simply an optional tactic when it comes to addressing tobacco use in Oklahoma. These efforts are targeted and evaluated. It's a sophisticated process and not just a random ad buy. It's exactly what the tobacco industry does. And we do it on a budget of $21.6 million to $172.6 million. So, speak on disparities briefly. Like many states, Oklahoma has pockets of people that are disproportionately affected by tobacco dependence, tobacco marketing, and tobacco price promotions. And as previously mentioned, there are many groups of people that are not fully protected. The tobacco industry has a product for every group and SLIP funding for marketing for different ethnic groups and ages. Of note, we tend to talk a lot about ACEs in the legislature. ACEs are correlated with higher rates of tobacco use. So that's certainly one way we could address those scores. Individuals impacted by mental health and substance abuse disorders have higher rates of tobacco use, and research shows that continued tobacco use impacts treatment and recovery. And these populations have been unfairly targeted by the tobacco industry. In many of these statements I make, these are public record. These are industry documents that were dumped after 2000. Early 2000s, and I can provide that resource to everyone if you would like. So, we must ensure that we allocate resources for all of these populations, and strategies and interventions must be provided in an effective way, and these disparities must be addressed if we want to be a top 10 state.
Thank you for your comments and recommendations, both of you. Appreciate you being here. Questions, Senator Hicks.
Thank you, Mr. Chair. I have a question specific to the slide on smoking and chronic diseases. There is, I guess, very preliminary data that is coming out currently that links smoking to type 2 diabetes, and obviously the amount of deaths are not reflected here in this slide that might be type 2 diabetes related deaths. Is there a way that we can also capture some of that data to paint a more accurate picture?
So we do have documents. I didn't include it in this one. We do have the rates. I can get that for you. I don't know it off the top of my head, but I do have that information.
Representative Newton, you're recognized.
Thank you, Mr. Chair. Just some couple of questions here regarding this. On your study earlier there on your burden of smoking among youth and adults, you talked about the percentage of smokers. Now, does that include electronic and standard cigarettes, or is that just standard cigarettes?
This is Kristen Kirchenbauer. It is just cigarettes. So the way the question is asked on Burfus, asked specifically for cigarettes.
Follow up.
Thank you, Mr. Chairman. Okay, so looking at youth, underage smoking, and all that, currently, is it not illegal, or you have to show ID to show that you're 18 years of age to purchase a pack of cigarettes?
Yes, that is correct. So we do have youth access laws that require that they have to show, but what we are finding, so I'm not sure if you are familiar with SINAR. It's a federal regulation that requires all states to do a study to look at compliance of underage sales. So all of the states do this. That's the SINAR rate. And so ABLE goes out and does these compliance checks based on a random sample from the retailer licenses. We take that sample, clean it, and then they go out and do these checks. And so what they're finding, and I don't want to speak on behalf of the Department of Mental Health, but what they find is that even though they're checking the IDs, they're still selling. So the non-compliance rate is at 18% for Oklahoma currently.
Follow up.
Thank you, Mr. Chair. So what are some of the states doing that are better than us as far as eliminating youth smoking versus what we're currently doing?
So what they're looking at is, as Scott previously mentioned, they're regulating or e-cigarettes and tobacco products similarly. They're also increasing the fees or fines associated with when a retailer sells to an underage minor. They're also increasing the licensing fees, and currently it's $30 for it's 2 or 3 years. I can't remember is how often they have to renew it. So some states are increasing those licensing fees, and then they're dedicating that money for enforcement outside of the federal requirements through SINAR.
Follow up.
So currently, if I want to make sure I clarified on this, regarding the electronic cigarettes, there is no stipulation on 18 years of age or?
No, there are. So vapor products are included in the youth access laws. What's missing is that we do not, e-cigarettes are not required for the SINAR study. And so I don't want to speak on behalf of ABLE, but there's nothing that requires them in statute that I'm aware of that requires them to do compliance check for e-cigarette location or those brick and mortar stores that sell e-cigarettes. But it is illegal to sell vapor products to anyone under the age of 18.
Follow up.
One more follow-up. Just on your studies up there, you showed Native Americans were highest as far as people group. So since they don't have to pay taxes and get the product at a cheaper rate, is that a factor?
So the compact rates, I'll be honest, I'm not as well versed in the compacts. The person who handled that just recently retired from the health department, but they pay the same amount for tax. So, and they comply with the 18-year-old to purchase as well. So I don't believe that would impact the rates. And I should also note, SINAR, they don't do these compliance checks for tribal affiliated locations.
Okay, thank you.
Representative Stark.
Thank you, Mr. Chair. My question has to do with your slides start at 9th grade. Do we have studies for 3rd grade? Or do we just look at high school?
So we used to do a survey that was called the Youth Tobacco Survey. We also had the Adult Tobacco Survey, but due to the costs associated with that and the CDC pulling out funding for support for states, we no longer provide that. And I believe that was grade school, so I think it was 5th, and I can get the exact ages, but I do think that's something we should address because of the fact that we're noticing e-cigarette use among even young as below middle school.
Follow up.
Thank you. So does TSET do education in grade school or elementary?
So I don't want to speak on behalf of the Tobacco Settlement Endowment Trust. A lot of the education that occurs for tobacco control is not curriculum based. So the CDC does not, they don't allow us to use funds on direct services such as educating individuals on one-on-one. They like us to use the money for mass media campaigns. I think that the landscape will be changing with the insurgence of e-cigarettes because there is a level of education that needs to happen. And I know that they've put out some curriculum recently around e-cigarettes that states can use.
Thank you.
Representative Ranson.
Thank you, Mr. Chair. So back, please correct me if I'm wrong. So the added tax to cigarettes is for cigarettes only, not e-cigarettes. Is that correct?
So are you referring to the 2018 tax increase? Yes. So that was for little cigars and cigarettes. So there's parity among those two products, but it was not for e-cigarettes. Currently, for e-cigarettes, they have to have just a sales tax permit. So there is no additional tax added to e-cigarettes.
Okay. Follow up?
Follow up.
Thank you. So to this slide, it says cigarette prices and sales in Oklahoma, where if the tax goes up on the cigarettes, the purchase of the cigarettes goes down. Then my thought is, by seeing this, does not necessarily tell me that we have less smokers. We have an increased use of e-cigarettes to avoid the high cost, correct?
So not necessarily. The problem that we have nationally is that we don't have the data like we do for tax data. So across the nation, we can make comparisons to all of the states because every single state taxes tobacco. E-cigarettes it's new and emerging. Some states do tax e-cigarettes or the juice or the products. We're not there yet, so to look at it across the nation's kind of impossible right now. But can you repeat your question? I'm sorry, I lost my train of thought.
You're recognized.
Thank you. This chart does not reflect that we have less smokers.
Yes.
It's possible we have more e-cigarette smokers.
So whenever I asked the CDC about this, Dr. Brian King has come to the state multiple times over the last year. I asked them about that. They've pulled Nielsen data to look at barcodes, and they're not seeing that people are switching over. This is accounting for the drop in consumption. That was our thought as well at the health department. And he said that in the last study, and I have that journal article, I can send it to you if you're interested, but they're not finding that it's a case of switching. We know that consumption continually declines. There's usually a 2% background decline in regards to consumption data. And when you increase the price at least 10%, you'll see an additional 4% decline in consumption. And so this does not say how many fewer smokers we have. It just tells us how much of the product is being consumed. And that's why we use consumption data and then the Burfus data and surveillance data to get a better picture of use in Oklahoma.
Thank you.
Representative Rowe.
Thank you, Mr. Chair. My question would be, how does the advertising laws different between, say, cigarettes and electronic devices? Because, you know, we don't advertise for Marlboros anymore like we used to, but you can't open the newspaper or a magazine or turn the TV on without seeing a Juul advertisement.
That's because the vapor industry is unregulated at the moment. For instance, for example, Juul only took steps to address its Marlboro-like advertising after the FDA started getting a little bit more heavy-handed. So, under the guise of voluntarily shutting down social media influences on Instagram, on Facebook, etc. I think they still might have an Instagram, but you've got to somehow prove of age. They voluntarily made those adjustments because they saw, the writing on the wall that regulation is coming.
Follow up.
So I'm not sure how to ask this question. So that the advertising laws, say like for the Marlboro, is those kind of regulations on advertising like in the newspapers and such, is that something that needs to be regulated at a state level, or does that have to come from a federal level? And I guess where I'm going with that is the advertising in local media such as newspapers something we can do as a state legislature to curb the advertising of these vapor products?
Yes.
I have a question on your annual costs incurred from Oklahoma smoking slide. It looks like that you got your data there from tobaccofreekids.org. I'm wondering why you got the data there and not from the health department's actual measurements.
So this is typically, we use these numbers because the Campaign for Tobacco-Free Kids basically uses data so we can have comparison across. It's also difficult, as we heard in the previous presentation, for us to really narrow down the cost. A few years ago, the health department had, I believe it was a grant, but it was OSIM, and we were trying to look at the cost attributed for Medicaid. It was very difficult, from my understanding, to get a good idea of what the costs were.
Thank you for answering that question. Representative Fugate, you're recognized.
Thank you, Mr. Chair. I think we heard as part of the presentation an estimate that about 26,000 people quit smoking because of Medicaid expansion due to increased access to preventative services in the state of Ohio. This is a two-part question. If we had a magic wand and we could wave it today and implement Medicaid expansion, do we have the resources available in this state, the kind of preventative services available for those people? And two, has there been any kind of extrapolation done for the state of Oklahoma about what numbers we might see if we did something like that?
First, I'd like to make one thing very clear. ACS CAN does not have a position currently on the ongoing ballot initiative here in Oklahoma to expand Medicaid. So I just want to be clear about that. As far as is the infrastructure in place to deliver these preventative cessation services, yes, we do. The quit line, another great example. It is we are one of a few states that actually opens up the quit line to all Oklahomans. So that infrastructure is there in part by TSET. And then, sorry, what was your second part of your question?
Recognized.
Thank you, Mr. Chair. So the second part of that was, do we have any extrapolations about the numbers of Oklahomans by comparison? If it's 26,000 in Ohio, is it 15,000 in Oklahoma or 35,000? Maybe we have more smokers?
I'll let Kristen answer that.
In regards to how we compare to Ohio, I don't have the numbers off the top of my head, but in regards to how this has worked in the past and what we've done, so the health department and the healthcare authority in partnership with TSET had a quality improvement work group a few years ago, and there were many topics that were addressed, with tobacco being one of them. The Medicaid agency looked at their policies to essentially get more folks using the benefits, and so they did a cost analysis on their end, and I'm not going to speak to what that looked like, but essentially removing barriers. So they already have a comprehensive benefits. They cover all of the 7 cessation aids, and they cover counseling as well. But they wanted to look at removing those barriers. And so they did do that, and they've seen an increase. They did a cost analysis to see if removing those barriers would impact the bottom line. And they've removed the barriers, which was copays, duration limits, prior authorizations, and they've seen an increase. So I know that they have the ability or capability to do that, but I just don't know what we look like in comparison to Ohio.
I'm going to go back to Representative Rowe. I neglected to give her a follow-up. Sorry.
Thank you, Mr. Chair. Do we know how many other states, I know, and I can't remember the state off the top of my head. There was recently a state passed or tried to pass raising the smoking or the purchase of tobacco products age to 21. Do we know how many other states have a 21 to purchase tobacco or tobacco products age limit?
We came prepared. We have model policy here for the American Heart Association campaign for tobacco-free kids, ACS CAN, etc. I believe the number is 21 or 22 brought up T21 last year during legislative session with 16.
Please speak into the mic. We have information here. David, did you say 18 states?
18 states?
July 30th, 2019, 18 states.
Passed it? Did they pass it, or was it just put on?
And it would include municipalities as well. So we have a report here. This is ACS CAN's How Do You Measure Up report, annual report just came out. There is a special section in here on T21 entitled A Wolf in Sheep's Clothing. So we have seen efforts across the country, and it's well documented in the press about the industry's efforts to undermine T21 laws. It's certainly a hard issue, right? But there is no evidence base for T21. But let me give you an example. Our neighbors to the east, Arkansas, this past year, they raised the level, the tobacco age to 21. That was a bill promoted by the industry. That bill, unfortunately, we, ACS CAN, had to go on the record against, because where that bill sounds great, it put preemption into place in Arkansas and took away the ability of local communities to decide on their health outcomes. But at the same time, they also put in research dollars for cancer research dollars that would have gone to the university system there. So it made it a very politically hard bill to vote against, right? I mean, you have a bill that looks great, sounds great, but in reality, it took a step backwards in tobacco control in Arkansas.
Yes, T21 means, for those who are wondering, that they would raise the legal buying age to 21 on tobacco products. And David has just let us know that 18 states did raise to 21 years of age.
And I think it's also important that, if we were, say, to go down that route of raising the age to 21, we would still have to fund enforcement.
Okay, Senator McCourtney.
Thank you. So last summer, I had the great joy of spending the whole summer working on marijuana, and this summer I've got this. So the handout that you passed out wasn't on the slides, but you passed out, seems to indicate that we have no clean indoor air policy at all. I know that to be false because of all the work that I did on marijuana, so I'm going to ask for you to clarify what you mean when you say we have no policy.
Certainly. We meant no offense. So we do not have a comprehensive clean indoor air policy. There are still loopholes in our statute, specifically for restaurants and bars. And your House Bill 2601 with Representative Fettgatter, you added marijuana combustible and vapor to the clean indoor air laws as well.
Follow up.
So the change that it would require for us to move from no policy to comprehensive policy would be to take out the current exemption in that clean indoor air policy of restaurants and bars. That moves us from no all the way to comprehensive. Is that correct?
Majority, yes.
Follow
up. Changing the subject a little bit, I was interested to see that on your recommendations, one thing that I thought that would come up was missing, and so I want to make sure, obviously it's been brought up a couple of times here. You brought up Medicaid expansion. We're looking at health insurance next week. You don't have a recommendation that we allow insurance companies to price people different depending on their tobacco use status. I know a lot of states have done that. Do you not recommend it because it hasn't been successful in other states, or we haven't seen it change anything in other states?
I'm sorry, could you repeat that last part?
You're recognized.
There are other states, there are many states, I believe, who allow insurance companies to price premiums based on your smoker status. In Oklahoma, you cannot do that, from my understanding. I was a little surprised that that's not one of your recommendations, and so I'm wondering if you didn't recommend that because we haven't seen that change people's behavior in other states?
So we would certainly oppose any effort to penalize a smoker. We are not against smokers. We are against smoking.
Okay. I actually sell insurance for a living. We do that on life insurance policies. I mean, the companies do that on life insurance policies all the time. If you're a smoker, there's demonstrable evidence that you're probably going to die early. And so they rate based on that. I'm just curious why you would take that position. I'm just curious.
The reality is that punishment, that is not an evidence-based practice. So there are other things that we can do beyond penalizing them through an insurance plan, et cetera, to address smoking. So clean indoor air being tobacco tax.
I'm going to let you off the hook. Pro Tem Wright, you're okay. Senator Stanislawski, you're recognized.
Thank you. I'll try to make these quick. So on your slides, on one of them it talks about electronic vapor products use. You don't have to find it because I'm just going to quote it if you want. Electronic vapor use products use among youth in Oklahoma. From 2015 to 2017, there was a 31% decline of youth using vapor products. Personally, I'd call that pretty doggone significant. 31%, one-third less almost. And when I turn to the page of the burden of smoking among youth in Oklahoma, so this is, I guess, all smoking, non-vapes, from 2005 to 2017, it's a 56% decline. That also is over half less now smoking. What's bad with that? Because it doesn't sound like that's a very positive thing. And actually, what are we doing right that's making that happen? That's pretty significant in my book.
So two things. We think that the e-cigarette rates, and this is nationally as well, they're underestimated. The way that the survey questions are asked, they say, do you use an e-cigarette? They don't consider themselves e-cigarette users. So the verbiage matters here. And the CDC is looking at how the survey instruments are provided to youth to change that. They consider themselves jewelers or jeweling. So we think that the rates are extremely underestimated. That's one answer. We still have the 5th highest rate. So yes, we've seen declines. It's great. We're happy. But it should be 0 because we know that we're going to have a whole nother generation of addicted smokers and the health outcomes are not going to get better. We're not going to get to a top 10 state. So even though we've seen these reductions, we're happy about it, but it's still high. In regards to what we are doing correctly, I think a lot of the initiatives that have been put forward at the local level, so prime example, the local level grantees have worked with those school districts to do voluntary policy. So a prime example of what we did right is 80% of the schools were covered by voluntary policies before the legislature passed the law. And with the addition of e-cigarettes, it allows the schools to enforce and restrict that, but we still have a lot of other problems that Scott mentioned in regards to access to these products and use.
Follow up.
On the second slide, smoking by social determinants of health. And you break it out with race, ethnicity. The highest one in 2017, the highest prevalence of smoking was 29.7% among American Indians. And that's substantially higher than any other group, substantially higher. So I'm going to ask a couple of quick questions concerning this specifically. What are we doing as a state, or what are the tribes doing to help decrease that we can help support them and get that number down? Because that is a very high number for them.
So I'll speak in generalities because they're all different and I don't want to speak for them, but essentially I know that a lot of the tribes and some of the ones that we fund are working on health systems change. So you have Chickasaw Nation that already have implemented evidence-based strategies for cessation. We are working with Muskogee Creek, Choctaw Nation, I'm missing one, Cheyenne and Arapaho and Muskogee Creek. So they are working on health systems change and they're working on policies. Cherokee Nation, I miss Cherokee Nation, internally. But I think the obvious answer is that we know that the tobacco industry targets specific populations, American Indians being one of them. And so I don't want to make any policy recommendations, but as Scott previously said, those evidence-based strategies will help push down the rates. The price increases that he said, other things that he mentioned will push down the rates among most of the populations in Oklahoma.
Okay, and final question.
Sure.
You had mentioned that in restaurants and bars that the air conditioning, give me the right word on that, filtration system, ventilation system, it just doesn't work. No matter how good the ventilation system is, it just does not work. So I guess my question is, for myself personally, the last time I was in a restaurant in Oklahoma that had smoking in it was probably about 5-10 years ago. I haven't visited any towns. I know they're out there. I'm sure there are. But by far the very high percent is not using ventilation systems. They just don't have smoking, period. So I'm not sure how much that's going to really help curb by just totally 100% banning it. And so my question really is, so I had a meeting last week, and the meeting was within a casino. And going through the casino to get to the meeting room, I'm going to guess at least 80% of the folks there are smoking. Now, ventilation systems are not adequate within a restaurant, and you got 80% of the people, approximately, I'm guessing again, within a casino that are smoking, and it's inadequate. How are we helping them to curb that? Because obviously that's a problem.
So to clarify, your question is what is happening at the state level to address smoking within casinos?
Well, it's apparent that by your statement that ventilation systems are inadequate, and I've not been in a restaurant where there's been smokers, yet walking through a casino there were a substantial number of smokers, and if the ventilation system is inadequate, how's the state or how's the tribes? I mean, they're a separate entity, I understand, their own nation. But is there something being done there to highlight that? Because that's a serious concern. And it wasn't a small casino, and it wasn't 2 or 3 people. We're talking hundreds, thousands visiting daily with that type of, and I'm concerned about not just the people there, but the workers there in that environment and secondhand smoke that they have to deal with too. So help me understand what's being done there to highlight that as a problem and help make change in that environment.
So I would simply say that, we respect the sovereignty of our tribes. I can't speak to what our efforts are when it comes to addressing ventilation within casinos.
And members, we're running long, so I'm closing the queue. We need to break for lunch in a moment. We've got 4 members still in the queue. Pro Tem Wright, do you still have a question?
Thank you very much, Mr. Chairman. I appreciate Senator Stanislawski bringing up and giving me the opportunity to plug my bill, and his bill, by the way. But talk a little bit about, we don't have policy, but there is a bill in the hopper right now, and talk a little bit about what that bill would do in an effort to try to curb smoking in Oklahoma and some of the problems we've been addressing this morning.
Yes, so shameless plug. Thank you to Representative Wright and Senator Stanislawski for carrying our clean indoor air bill for the past legislative session. That was House Bill 2288. It did make it out of the House Public Health Committee that would close the loopholes. There are certainly concerns expressed around cigar-based businesses. We are certainly willing to look at these issues and work together to get a product that would be acceptable to the vast majority of parties in that specific area.
Follow up.
Thank you very much, Mr. Chairman. Okay, so you've talked a lot about the secondhand smoke issues. Would a more comprehensive bill, it looks like from what you've said here, would you agree that it would help to curb some of the issues that problems that smoking cause in the state of Oklahoma?
Yes.
Thank you very much.
Senator Coleman, you're recognized.
Thank you, Mr. Chairman. On your slide that showed a pack of cigarettes at $7.14, is there any way to compare that with vaping? If I'm a 2-pack-a-day smoker, then how much do I buy in vape?
So the science is a little bit difficult because of the way the products are not fully regulated by the FDA. I think once those regulations go into effect, it might be a little bit easier, but the hard part is they do the concentration. So it's nicotine per milliliter. And so it's very hard to make comparisons. Also, if there ever is a time in which we have retailer licensing, we could see how much product is being sold, similar to how tobacco is currently captured through consumption data through the tax commission.
Follow up.
And currently, we don't have retail licensing for vape stores in Oklahoma, is that correct?
No, we do not. They have to have the sales tax permit. So there's not a tobacco tax for e-cigarettes or vapor.
Senator Hicks.
Thank you, Mr. Chair. I did have a question about online sales as it relates to tobacco products. Obviously, coming from the classroom previously, kids self-report that they buy products online. What are our current regulations, or are there current regulations on how online sales as it relates to not only the tobacco or nicotine itself, but the accessories, if you will?
So it is illegal to transport tobacco products across state lines, conventional tobacco products. E-cigarettes, a little bit more difficult. They're not regulated that way. States do have the opportunity to regulate it, so internet sales, you could impact that. The research is new, and so I could look into that if you are interested and get the research or evidence base behind other states that have addressed this, but you are correct. What they'll do, they have very many techniques to get these products. They can, if they're a junior, for instance, they can use their father's license, and they can get one of the prepaid cards and get those Amazon to deliver it before their parents get home. So it's very much a problem on the e-commerce side.
Our final questions come from Representative Stark.
Thank you, Mr. Chairman. On the Juuls and the vaping products, they are hard to identify. And, so, if you're not current on what they look like, do you know if there's an initiative through the Department of Education or through anyone in the state to educate educators and administrators as to what those look like and how to identify them and keep them out of their classroom?
So the Oklahoma State Department of Health, TSET, and the local grantees, we're working with OSDE. The recent law that went into effect, including vapor and the 24/7, we have reached out and we hope to have some information. The health department and the CDC is pushing out information to those local level grantees. So we have created documents, resources, especially for cessation. That's a hot topic for youth because they are becoming readily addicted to this because of the nicotine content. The CDC has also pushed out a lot of information. There's Catch My Breath. There is some curriculum that has the notes in it that the CDC has put out. So there's quite a few initiatives happening. I think TSET and OSDH and OSDE will be working more as the years to come on coordinating those efforts.
Okay, there's no more questions in the queue. Members, we're going to take a break for lunch. We'll be back here at 1 o'clock. Thank you both for your recommendations today. Smoking's really bad. See you after lunch. And so the quicker we start, perhaps the quicker we're driving home. Our first presenter is Jennifer Ferries with the Route 66 project. Jennifer, we appreciate you being here. Jennifer, just before you speak, if you would introduce yourself, and we can go ahead and get started now.
So thank you guys all for having us. My name is Jennifer Ferris. I work at MyHealth. I work on a federal project called Accountable Health Communities. It is a consortium of Oklahoma providers and community partners. So we named it the Route 66 Consortium. My background is I was a mental health therapist for 10 years, spent a lot of time with abused and neglected youth. I worked in an urban clinic in Boston and in Houston, as well as did therapeutic foster care here in Oklahoma. And then I took a few years and raised a couple of babies. Is it better? Yeah, from the peanut gallery. And spent the last 4 or 5 years in business development and finance. And so I have recently come back to this space, talking about social determinants of health, what matters, what's important for, why do patients really not get healthy? The more money we spend on healthcare. So sort of thinking innovatively about what else needs to be involved to truly make patients better. So I'm not going to speak a whole lot about social determinants of health. I think some of the presenters this afternoon are going to share a lot of details about this. But what we're talking about to sort of lay a framework so I can tell you about the federal project that we're working on is the conditions around which people live, work, and play. So not just their healthcare appointments, the medications they take, We're really talking about the world they live in, their access to education, their economic status, and the way that they use healthy behaviors. So not just how they take their medication or how often they see a primary care physician, but how do they live a healthy life. Okay, so I'm going to start by telling you two stories. This is a project called the Accountable Health Communities. It is a federal project funded by CMS. My Health is the bridge organization. So that just means that we are a bridge between community partners and clinical delivery systems. So I want to tell you about two of the patients that we have helped and impacted in this project. So the first one is John. John is a grandfather who received our social determinants screening, took it, and indicated that he had needs in the areas of housing, transportation, and food. So he received resources from us, but then our navigators, our partners at the Oklahoma City County Health Department, picked up the phone and called him. And he said, that's not exactly the whole story, right? In my house, my grown children and my 7 grandchildren live here, and we're trying to live off of the money that I make from my retirement. And so John, we connected him and got him set up an appointment to go to Catholic Charities. Okay. So he went to Catholic Charities and he got food, a bag of food for his family, a couple of different resources, and was able to go home and provide food for the next week for his family. But during that process, Catholic Charities also hooked him up with gifts and turkey dinner for Thanksgiving, gifts for Christmas. And he said the next time we called and followed up on him is, for the first time ever, my grandchildren have a normal Christmas. And so this was all because he indicated at a doctor's appointment that he had some needs outside of his medical needs. The second patient that I want to tell you about is Julie. And Julie is a pregnant mom with a 13-month-old child. And we identified her at an OBGYN clinic. And Julie indicated that she had food needs and some domestic violence. And so the first couple of times we tried to call her, we didn't get in touch with her. After we finally were able to get in touch with her, we found out that when her boyfriend is in the home, she doesn't answer the phone, right? The phone call came from the Tulsa Health Department. And so she had some indication that maybe this was a call she didn't want to take with her boyfriend in the home. So we found out that she had not been able on her own to go down and apply for SNAP. She couldn't figure it out. She gave up. It was too hard. She couldn't do it. So our navigator actually called and made her an appointment with an officer to go down that day. She got food stamps that day. Her family got taken care of. She was so excited that she was now able to take her prenatal vitamins and get food and all the things she was trying to do that she referred 2 friends who picked up the phone and called our navigator. So these are just 2 stories of the work that we're trying to do through this project. All of these needs are identified in a physician's office when they were there for medical appointments, and really there was a whole lot more to the story than just what they were there for that day. So I'm going to tell you how the consortium was formed. So in 2017, a group of people from Oklahoma came together and said, we need to apply for this grant. It's actually a cooperative agreement, but a grant from CMS. We need this in Oklahoma. We need to be figuring out what do our beneficiaries in Oklahoma need outside of just medical appointments. So they came together. These are all of the groups that signed memorandums of understanding supporting the project and saying, we want to apply for this as a state. They decided to go ahead and have My Health apply as the bridge organization because we already have data connections with a lot of these groups. And so it kind of made sense. We actually didn't intend to apply. All of these groups came together and said, we all want to participate. So if only one of us applies, then it's our health system that gets to participate. If we all apply together, then it's a joint state effort. So these are just a few of the people who came together. So a few details about this federal project. It is a cooperative agreement, like I said. The bottom line, right, you want to know what the bottom line is. CMS is trying to determine if identifying, addressing, and treating health-related social needs will reduce healthcare costs and unnecessary utilization, right? So what we're trying to target here is people who are going to the ER because they don't have a ride to their physician's office. They can call IMSA, right, and get a ride to the ER. And that's way more expensive than us helping them find bus tokens to take the bus to their physician's office. So in this project, we are starting with just studying the 5 core needs. And these are the needs that are required by CMS. There are actually other things on top of this, such as mental health and substance abuse, that we could add. So we're looking at, do people have housing instability and quality needs, food insecurity, transportation, utilities, and domestic violence? So those are the core areas that we're focusing on. So this is sort of the general structure of the project. So we sit in the middle as the bridge organization, and really what our job is to help clinical sites screen their patients for what are their social needs. We want them to, it's the patients in those clinical sites who need assistance, and so we are essentially doing the screening on behalf of the provider. So on the backside of this, we actually reply back, or we send back to the provider the information on their patients, so they can provide a more holistic view of healthcare. So we sit in the middle as the bridge organizations, and then we connect people who identified needs in these settings, FQHCs, hospitals, clinics, behavioral health systems, and we connect them to existing community service providers. So this project does not allow for any funding. We cannot spend our funding on resources. Our job is to connect people with existing community resources that already exist in our community that a lot of people who are really high needs, they don't know how to access, right? They don't know how to call and set up an appointment to get a SNAP application done. Or they go to the food pantry and it's only open on Wednesdays from 6 to 7 and they use $10 to get there, right? So there's a lot of limitations. So it's our job to help connect people who have needs to community resources. So this is the very basics of how it works. So a patient checks into a clinical delivery site. And because at MyHealth we have what we call admission, discharge, and transfer messages, when someone checks in there, we know that they arrived and that they're there for their appointment. When they check in, we then pull mobile numbers out of their message that comes to us from their electronic medical record, and we text them a social needs screening. So all of this is done within 2 minutes of check-in. So the goal here is to provide the greatest benefit for the patient with the least amount of burden for providers. When we finally received the questionnaire we had to use from CMS, it was 20 questions as a base questionnaire. And so we went back to our partners and said, great, now you guys get to help us screen people. And they all said, there's no way, right? We don't have 12 minutes in a clinical encounter to ask our patients 20 more questions. So we went to the drawing board and we came up with this method of screening. So the patient gets the text message on their mobile device. Most patients, it takes between 2 and 4 minutes to complete it on their own. The clinical delivery sites, we encourage them to tell patients if they have Wi-Fi. They can do it right there in the office, doesn't cost them anything. And then within 5 minutes of them completing that screening, they actually get back another message from us with resources custom to their home address. So we give patients resources for, let's say, food. It has 3 resources. One we give is a federal or a state resource. So we give everybody instructions on how to apply for SNAP. We give everyone the National Domestic Violence Hotline if that's their need. We then give them one resource that we've identified in our community is really high quality, where we know they can go get help without a lot of red tape. Maybe that's Palomar or Divis or Catholic Charities. And then the third resource we give them is literally the closest resource to their home address. So maybe a little food pantry in a church basement that you or I would never know of, right? But it's in our database, so we can return that based on their home address. So everyone gets resources and everyone gets screened. CMS actually just funds Medicare and Medicaid. We've decided that wasn't appropriate, right? MyHealth is covering the cost to screen uninsured and commercially insured people because we know they have a lot of needs, and we felt like as a community effort, it wasn't fair, right, to just say only certain people get assistance. So we're screening everyone. And then on the back end, we have partnerships with the Tulsa County Health Department and the Oklahoma City County Health Department. And we employ 12 navigators at those sites who then the next day pick up the phone. They get a report from us of everyone who was screened. And those patients who CMS has determined are high risk, and that means someone who's been to the ER 2 times or more, they pick up the phone and they call those people. And they say, hey, based on your screening, can we help connect you to resources? Can we get you help with some of these social determinants of health that you've indicated you need assistance with? And what we're trying to do here, what CMS is trying to do, and what we're trying to help them do, is really target those high utilizers who are costing our state so much money when really maybe they just need some assistance getting to the right place at the right time. So that's sort of how the model works. So originally when we applied for this project, we applied just for Tulsa and Oklahoma County. We learned pretty quickly that obviously there were a whole lot of needs outside of those two big counties. And people that were being seen in doctor's offices in Tulsa and Oklahoma County lived lots of other places. And so we applied to CMS and received an expansion. So this project is now available for the entire state of Oklahoma. So any Oklahoman living anywhere is eligible to participate in the social needs screening. So I'm going to show you, this is what it looks like. Everyone wants to know, like, what is it really? This is how it shows up on your cell phone. It's actually very easy. It's easy to take. The first question we ask is, do you want to take it in English or Spanish? We have it available in both languages. There's privacy notices and consent. And then we start in on our questions about social needs. So the very first question is, within the past 12 months, were you worried that your food would run out before you got money to buy more? And one thing I do like about these questions is they don't ask just, do you have a place to live or do you have food, but are you worried it won't last? The money that you have to meet these needs won't last you the whole month. There's a transportation question, and then a question about utilities. There are then 4 additional questions about domestic violence, and they ask about things like emotional abuse, physical abuse, yelling and screaming in your home. It actually is more detailed than just, do you live in a violent home? They actually ask you about the specific types of violence that they may encounter so that we can then be sure we direct them to the right place. So part of our project is that we have to have available resources in every county that we offer the screening. So we've created a database that is right now, I think it's 5,800 or 4,800 resources in our database. All 77 counties have resources available. Obviously, over in the Panhandle, there's a few less resources available than Tulsa and Oklahoma County, but we had to make sure that we could meet people's needs. When they identified a need, we were able to meet them. And this is actually what the resources look like when they come back on a patient's phone. So as you can see, the blue phone numbers and email are clickable links. So for example, we're doing this at OU Medical here in the city. So someone sitting in the waiting room at OU Medical could literally just click that phone number and it'll call a food pantry. And they could go there on their way home from their ER visit. So data, so you wanna know, we've been doing this now for a year. We think it's been really interesting to see what's come out of this and what we've been able to identify. So the first thing is we know some people self-select out. Right? If you go to the doctor and you get the screening and you answer the first question and then you see it's about social needs, you might choose not to take it, right? And so we know there's some self-selection out, which is represented by that green part. Then, as you can see, we started in 2 clinics in August. And so because of this mobile technology and the infrastructure that we've built, we can now deploy this very easily in lots of locations. The first 2 months were tough, but now we kind of have the hang of it. And so this is an easy way to offer screenings to lots of people, and it's very scalable. So we can now roll this out to any clinic in the state of Oklahoma. So overall, out of 12 months of data, 23% of every person who takes the screening indicates they have some sort of social need. And these are commercially insured, uninsured, Medicare, and then here's the breakdown by payer class. So it's probably no surprise to you that uninsured and Medicaid have the highest need rate, right? Those are the people we need to target. Those are the people who are driving up healthcare costs in Oklahoma because they don't have, for uninsured, they don't have any coverage. And for Medicaid patients, a lot of times they don't have the insurance they need to help meet some of the needs, like substance abuse or mental health. And then this is just the breakdown so that you can see kind of what's being reported in our community. Obviously, the highest need reported by anyone is food. Surprisingly, utility need is the highest reported need for the uninsured and Medicaid. And you know, as we've started doing this work, one thing we realized, there are a lot of places you can go to get food in Oklahoma. There are places that you can go to get assistance with your rent or get affordable housing. There are very few places you can go to get help with your utility bill, right? Most of them are faith-based organizations or community organizations, and they help one time with a bill that's already been shut off. So it's been interesting to see what are people in Oklahoma really reporting and what can we really provide for them. Okay, so in my other life, I also spent some time in finance. This is a very, very basic, rough ROI calculation. So if we took 12 minutes to screen every patient that walked in the door of every clinical encounter that comes through MyHealth, 45,000 clinical encounters a day from the state, and it takes that clinic staff, we use a medical assistant who makes $10 an hour, it's gonna cost us $32 million a year to do that. There's no way, right? There's no money for that. Using this technology that we have to do mobile screenings, it's essentially 1 cent a person to screen them. It costs us 1 penny to send a screening text to every patient. We're using the clinical encounters that come through our system just as a baseline. And that would be if the technology wasn't built, right? That would be if we were able to deploy this after there's infrastructure built. So this project that CMS has funded has luckily provided the funding to build the infrastructure needed to get this project off the ground. We get about $900,000 a year for the project to build infrastructure for staff. We use this to pay our partners at Oklahoma City and Tulsa Health Department 12 employees who pick up the phone and call every high-risk individual. So as you can see, there's significant savings, even when we figure in infrastructure and all the technology that has to build. It's a significant amount of savings over trying to screen every person at every visit at every clinical site in person. So what is the takeaway? For us, and you're going to hear a lot more today about what are social determinants and why do they matter so much. We really wanted to show you what are we doing and what do we find based on the work we've done with Oklahomans in our state. The biggest thing we can tell you, and you're going to hear from other speakers why, but that the detection and ability to address social needs is critically important to overall health in our state. We're going to be able to intervene at a different level than medical providers. And not that their work is not absolutely essential, but it's the foundation that can help people get healthier lives. This work can be done at scale. You don't have to sit in an office and use 15 minutes of every clinical encounter to ask these questions. We can do the screening at scale and through mobile device or technology or whatever's already existing in our state, and then let the providers really spend time in a clinical visit to provide health care. And we really believe that this is how we help people get better, right? We always ask, we're spending billions of dollars a year, right, in healthcare. Why are people not getting better? Why are we still having sicker and sicker patients? And we think a lot of it has to do with the things going on in their life outside of did they take their diabetes medication? Because I'll tell you what, if they can't put food on the table for their children, they're not going to go have their diabetes medication filled. And we think this is a cost-effective method. There are lots of other methods. We're looking at lots of things. I think our state is truly being innovative. This project, this federal CMS project, is being done by 30 groups around the country. So Yale, University of Hawaii, University of Kentucky. We are the only ones, we're the only state doing technology-based mobile screening. And I will tell you, the CMS is looking very closely at what Oklahoma does in this project to say, what are the additional use cases for this? Right? Could we use this for other things, medication reconciliation or intake forms or opioid addiction referrals or smoking cessation referrals? What else could we use this technology that's already built in our state to provide assistance for the healthcare of Oklahomans? And the other thing is we believe that the real-time screening and reporting of these events is really important. It is a federal mandate as part of some of the CMS programs, CPC Plus, that they screen patients once a year. We really believe once a year isn't enough, right? If I have a job today and I lose my job tomorrow, 30 days from now, I'm in a very different state, potentially, than I was today. That's my presentation.
Thank you for that presentation. Representative Lawson, you have a question?
I do. Thank you, Mr. Chairman. I agree that assessment is important, but I didn't see anything as far as like follow-up goes. I'm hoping you could maybe give some insight. Let's say I present at the ER and I've got the screening and I'm say that I've got some food insecurity, and a month later I follow up with my primary care physician. Does my primary care physician have access to my screening? Who does a follow-up? Who does some sort of follow-up to see if my needs are being met?
Yeah, no, that's a great question. So as a part of this project, anyone screened in a same healthcare system, and this is all about consent, right? Who do we have consent to share this data with? So in a given health system, let's say, for example, Hillcrest, if you're seen in the ER and you indicate you have a food need and we provide you resources, those screening results are available to your provider. Through the HIE, we're still working through consent and how do we share patient records and all of that for social determinants. This hasn't been done before in Oklahoma. There are very clear rules on medical treatment. We would like to make this available as, in the portal so that an OU physician could see what was done at Hillcrest or a Hillcrest physician could see what was done at Integris. Some of that is still happening. There is, through this project, and this is the sort of piece that our health departments bring to us, all of the high-risk patients get follow-up for a solid year. So we follow up with them monthly, weekly, daily, whatever it takes to make sure that that referral loop is closed, right? So I told you you could go to the food bank, but do I know if you went? And do I know if it met your need? That's where we're using community health workers in the state to do that follow-up. I'll be honest, there's a lot more of that needed. But that's some of the work that is the way we truly know did someone get their needs met is how do we share the information, and then do we have staff available to do the follow-up? Does that answer your question?
Representative Ranson.
Thank you, Mr. Chair. So is the point of entry into this merely the physician?
So this project, funded by CMS, their requirement has to be during a clinical event. So for us, that can be care management, that can be an ER visit, a clinic visit, pharmacy visit. We are working on a partnership with IMSA, so that potentially they could be screened at IMSA. We know there are people that call IMSA but don't ever get to a clinical facility. If this wasn't a federal project and there weren't these rules, we could do it anywhere. Right? But as a part of this project, the requirement is the screening has to be done at a clinical event. Does that answer your question?
Okay.
Follow up.
You said that, but you did say that the ER is a place that they could go to as well.
Yeah. ER, physicians, behavioral health unit, behavioral health facility. Yeah. It's not just physician offices.
Senator Stanislawski, you're recognized.
Thank you, Mr. Chair. So on one of the pages, you mentioned the mobile screening process, and after patient check-in, a link to screening is sent via text. So two questions on that. It was the
I think it's
chart
the hidden
goes there.
slide I had. I didn't think I would have
Slide
enough
10?
time to do
Yeah,
all
10.
of these.
There you go, right there. So two quick questions.
Yeah.
One is, if a person is homeless, they do not have a cell phone, I guess they have to do it right there in some type of clinic setting to be able to do that because they can't get a text.
Yeah, so we get that question all the time, right? But after, Medicaid reimbursement phones and all the stuff that came out of Obamacare, we piloted this in the free Bedlam Clinic in Tulsa, the OU Bedlam Clinic. 100% of the patients who came in that door during that pilot period had a cell phone. Even though they were uninsured, low income, there are a lot of ways that people have cell phones. We do have methods that in a clinic, a clinical staff member could also screen them if they do not have a mobile device.
Okay.
And in addition, we have a link where they could go to a public library or wherever and screen themselves. So there are options.
And then quick follow-up is, do you ever envision creating an app so someone can have it on their cell phone? So if they've gone through the process, they're doing fine for several months, but all of a sudden, disaster strikes again, they can just go right back to the app and self-screen, and is that a possibility going forward?
Yeah,
What do you think?
So we have lots of ideas, right? CMS has said at this point it has to be at a clinical event. So our hands are really sort of tied by those criteria. We see this, obviously, once the funding runs out from CMS, as a project that we will deploy in lots more creative ways. And so the other thing is the link that a patient is sent right now. So the CMS language is it has to be initiated by a clinical encounter. I will tell you, the patients, as long as they have that link on their phone, they can take it whenever. It never expires, right? So they could take it 6 months from now. And we see that, actually, surprisingly. We have responses that come in 2, 3, 6 months later. So someone who probably was fine at the time and thought, oh, I remember there was something where I could get resources.
Senator Quinn.
Thank you, Mr. Chairman. Commend you for your efforts. You mentioned some of the presentation early on. You had a slide in there about the gentleman that you addressed and collected some additional information later on about how many in his family that he was trying to support. Using that as an example, when you find those situations, are y'all in a position to help try to stop that cycle, offer alternatives or new methods that would help stop that continued cycle for those members that are in those families? And just take your comments on that.
Yeah, so this is a kind of a sticky answer, but CMS says we can only treat the person screened. Now, I will tell you, when we call and we find out there are 7 people in a home and none of them have enough food to eat and none of them have anywhere to go to live other than their grandfather's house, our navigators are trained to provide assistance to everyone in that home. Some of our standard things we do to send to everyone is we send them all SNAP applications so they can figure out how, even if it's not just him, if it's the parent, the children, the grown children in his home, we give them all counseling referrals and connect them with community agencies to try. What we find a lot is that there's neglect issues or domestic violence issues. So our navigators at the health department are trained to not just meet someone's food need. And one thing we like to think about with this is that usually patients don't have a food need, they have a resource need, right? They don't have enough money to get through the month. So food may be the most salient thing they report, but the reality is they have to make a choice, right? Are they gonna help get their kids to school or to a doctor's appointment, or are they gonna provide food? And sometimes, what we find a lot is that people report food needs and we call and talk to them on the phone and they have 10 other needs, right? So we are cognizant of the fact that usually it is a systemic problem. It is a family generational problem. And we do everything in our power to try to provide direction, resources for all the people involved in that home, not just the identified patient from the clinic or the hospital.
Follow up.
So do you make efforts, or do you know if the agencies that you work with, are they making efforts to help in that particular area?
With
as far as stopping the cycle?
Yeah, I mean, I think the beauty of the people that we use, community health workers, are people who have what we call lived experience. And so they're people themselves who have been in situations where maybe they didn't have enough food to eat, or maybe they were in a domestic violence situation. So part of the reason we use those individuals is it is part of their skill set to say, here's how I got out of this. Here's how we could help you. And to make appropriate referrals in the community. Again, this is a CMS project, so we're kind of limited as to what we could do. We would love to then refer all of those people to, counseling services or a parenting program, or connect them with DHS or social services. We can only, with this project, we can only make referrals. So we try to meet and think about those generational sort of ongoing problems as much as we can. And to be honest, when this is not a federally regulated project, when we could say, okay, how does OU Med, how do they want to handle this? Do they want us to provide additional resources? Do they want us to refer them all back to their social workers? When we have a little more leeway, there's a lot of things we would like to add that we think could really make a difference in this work.
Thank you for coming. What I love about this program, and it's why I asked you to come, is because it starts to get at the root of some of these cultural problems we have. At least we can identify where we haven't been able to identify before, and these things that drive cost and more acute care needs. So I really appreciate what you're doing. Keep doing it. I want to ask some questions about nuts and bolts. So CMS, you're doing this through CMS. Was it through an innovation grant?
Yeah.
How is there matching funds? Where did you get your seed money? The navigators, who employs them? Is it MyHealth, or I'll let you go with that.
Yeah. So this project was MyHealth provided their own seed money, right? We staffed this until we could get funding. This is a project funded out of the CMMI Innovation Group, so the same group that tests value-based payment models. And so, what we all hope in our field comes out of this is some CMS funding to say this stuff matters and this should be included in healthcare plans, and CMS will reimburse for navigation services or more case management or additional funding outside of what they are currently paying for, so thinking more holistically about value-based payment. And so that is where this is funded from. It is a 5-year grant. We have 2.5 years left to do this. So the beauty is we have been able to use a lot of the CMS funds to build the infrastructure for this so that when the project is done, this project won't be done. Right? We've built the infrastructure, we've built the technology to be able to do this going forward. So hopefully a lot of the nuts and bolts that we have spent years working on and perfecting and trying to get off the ground, we don't have to start over, right? As a state, that technology exists at MyHealth and the HIE, and it exists already through the feeds that we have with EMRs. So there's nothing new that has to be built. So we hope that we can continue this work with maybe a little broader paintbrush stroke and reach more people. You asked about, the navigators. So we have really amazing partnerships with Tulsa Health Department and Oklahoma City County Health Department. We pay for the navigators out of our funding, but they are employed by the health departments. And part of that is that the health departments are great at, they have other community health workers. So they have peers, they have training, they have support staff, they have supervisors who support this work, who have already experienced doing this work. We also have partnered with the OU Sooner Health Access Network, and those care managers are actually doing this work too. Right? They feel like this is really important, and they want to contribute to the data that we're collecting also on what does Oklahoma need? What are truly the social needs that we can measure in the state? So, we're looking at finding lots of new partnerships and thinking outside the box. We have a proposal from Meals on Wheels to do a navigation partnership with them, right? They have already identified people who have food needs. And so they have a new slogan, a corporate slogan that's more than a meal. And so we're looking at trying to get them to be, we have to get CMS to agree that that's a clinical event when they go in and do their home safety assessments. And so we're really trying to think outside the box using the technology we already have. We don't have to build again. And the infrastructure already in place to continue to expand this project, relying on the data that's already available to us. And the beauty is that with health systems, we get their data and we're able to do this without much interruption at all to clinical staff. So when someone shows up at the ER, you can truly get treatment for the reason that they showed up at the ER, and we can support the rest of this sort of on the backside, right? So that hopefully next time that they have an emergency, we can assist them to get to their provider, not to the ER if that's not clinically appropriate for them.
Representative Fugate.
Thank you, Mr. Chair. I applaud what we're doing through this innovation process where we're reaching those folks who are involved with the healthcare system. I have 2 questions. One, do we have an estimate of the number of people who on an annual basis would never be involved with healthcare in Oklahoma? And 2, do you have any kind of usage tracking by age bands? Are there groups of people that, well, for example, might be resistant to using text messaging?
Mm-hmm. So that's sort of outside my wheelhouse of how many people don't access healthcare. I'm sure we could pull some data on it. We joke all the time that we'd like Dr. Kendrick to put on his white coat. Our office is next to the bus station in Tulsa. We'd love to go down there and screen people before they get to the ER, right? So that we could do intervention before expensive medical treatment happens. That's maybe unnecessary. You know, maybe those guys are cold and they don't have anywhere to go, so they know they can go to the St. John's ER and be there for 12 hours. So we would love to intervene outside of the clinical setting, but that's sort of not how this project is built. And the second part of your question was, age bands. So we have been doing this since August of last year. So we are collecting data. So I have not run the numbers on that. We can look at what are social needs by age bands and who's participating by age. And we have lots of analysis, right, that we're excited to do. We haven't quite got there. To be honest, we always say we're building the plane while we're flying it, right? So we're trying to get the project to going and expanded. I will tell you, our biggest challenge has been we are involved in one of the resident clinics here at OU Medical, the geriatric resident clinic. And they do have the lowest response rate. So they have clinical staff now, care managers in each of those clinics who are going to be screening patients in person. So again, it takes more time, it takes more effort, but at the same time, there are a lot of people, right, who we would love to be able to screen. The second question in the screening is, who are you taking this for? So a geriatric patient could give their daughter's cell phone and she could take it for them. So we do see a lot of that, people taking it for people they give care to.
Follow up.
Thank you, Mr. Chairman. Is there any kind of an interactive voice response system as part of this process, or is it strictly text messaging?
So right now it's text message. Again, we have big plans of what else we'll do. The most important part of this we found is that the clinical staff, where they get the text message, whether they take it then or not, they say, you know, this is from us. We really want you to take it. It'll provide you resources. And if you have any questions, let me know. And so at the clinical site, they can provide assistance. And I don't know if you noticed, but in our resources, we actually have, as a part of the intro to the resources, we give referral to 211. And we say, you can click this link and pick up the phone and someone will answer you immediately and help you meet your needs. So lots of big plans, not yet time or money to do that.
Representative Stark.
Thank you. Thank you, Mr. Chair. My question is kind of piggybacks on Representative Fugate's, because I do know many seniors don't have cell phones or do not text. And so you kind of answered that. What if, because they're the ones who have multiple generations, and that's what you find, even though this is not designed for that, is there something besides just a one-on-one that can make that happen? Or does it have to be just the person sitting in front of them realizes they don't have a cell phone number and they do the one-on-one right then, or how does that work?
Yeah, so again, the CMS rules are that this has to be triggered at a clinical event and the screening has to be initiated then. We have a little bit different rules for the ER where we can have navigators pick up the phone and call and screen people who did not take the screening, who probably didn't get it on their cell phone within 5 days. However, people that go to the doctor's office or the FQHC or the behavioral health unit, the rules of this project by CMS are that they have to be screened at that event. So again, the bounds of the work, and they're trying to study, right? If we do this, if we deploy this, if we pay for this in clinical settings, is it going to make a difference on healthcare costs and utilization? So I understand the limitations they put. We would like for the navigators to be able to pick up the phone and call anybody, right, who didn't complete it by text message. And we actually do, one of the things that's coming out of this is some interesting data is we are collecting delivered and undelivered data. So we know how many patients in a clinic they have a good mobile number and they can reach, because a lot of clinics do appointment reminders and all of that by text message now. So sort of a byproduct of this project is a lot of the clinics are using this to study how well can we reach patients through this methodology. So
Thank you. Can you connect with free clinics and with dental clinics? And are they already in your system, or how do they get on there?
Yeah, so we asked CMS can do dental. We went and asked them about dentists, IMSA, pharmacists, right? All of those are essentially clinical events. And they said, yes, we can use those avenues to connect to patients. We do have free clinics connected through My Health, and we do have some dental offices. We, to be perfectly honest, would love to screen in those locations. We haven't had interest yet. I think, from a dental office, they're maybe not thinking about this stuff yet. Free clinics we do, so the Bedlam Clinic, OU Physicians in Tulsa, we screen at the Women's Free Clinic, and that was sort of our first pilot there. And then the plan is to roll it out to the remaining free clinics that are part of OU Physicians. Yeah.
Follow up.
What about the nonprofit clinics and things that are out there that are not connected with a major source of healthcare?
Yeah, so if they are not connected to the HIE, we don't receive messages about their admissions or their admits. So they could certainly be a part of the project, and they could certainly screen patients. We just wouldn't be able to do the real-time text screening. But there is an avenue that clinics can use to screen their patients using our technology, our screening instrument. And then the reports will get sent back to us, and then we can use the health department navigators to follow up. So it's just a little different entry than text messaging. It would be sort of in-person screening.
One more. I have one more. Thank you. To me, that would help address some of the people who won't show up for medical care because they're going to their local free clinic down the road. I understand this is a grant and it has real specific things. Is there, but I did see this Regional Food Bank as one of your affiliates or partners. Is there, in the future, would there be a way to kind of do it in reverse?
Mm-hmm.
If you're in a food pantry, you would be contacted about whether or not you need health care.
Absolutely.
But that cannot be done now with the confines of the grant. Is that my understanding?
It is, yeah. And we would love to be able to screen people who are at a food pantry because, like we said, most people who show up at a food pantry with a food need, a lot of them have other needs as well, and a lot of them have healthcare needs.
Right.
And so it would be amazing to be able to say, we have great partnerships with the Regional Food Bank, with both the one in Tulsa and Oklahoma City, and they would, I think, be happy to jump right in and start offering this to their people. But based on the confines of this project, we cannot do that. It has to be initiated at a clinical event. Okay. So
Thank you.
There's lots of things planned.
Yeah, that's very interesting. Thank you.
Thank you.
Well, I don't see any more questions, so thank you very much for coming and presenting to us. It's a really cool program, and who would, I mean, it's so common sense, really, when you think about it, and that you guys actually did it. I mean, it's just, even though it's common sense, you don't see that much anymore. But thank you. Who? Oh, we do have one more question. But anyway, thank you so much for coming. We'll go to this last question, and we'll take a break.
Of course.
Thank you, Mr. Chair. I'm relaying a question from TJ Marty, who didn't get a chance to be here today, and he was wondered if you might speak for just a minute about pharmacies and how they might participate in this process, or how they do participate.
Yeah, so we have connected to My Health. We have I'm going to butcher the name, but the Independent Pharmacy Association. So several pharmacies through that organization. There are quite a few pharmacies connected to My Health. I will tell you the big chains, Walgreens and CVS, they are not yet sort of bought in to sort of local. How do I say this without stepping on myself? So yes, we have local and independent pharmacies. I will tell you, CMS said to be able to participate in the grant, that someone who goes to a pharmacy for medication information or gets some medication counseling, that would qualify as a clinical event. If you stop at Walgreens and pick up your meds at the drive-through window, they say that doesn't qualify. So again, that would be a perfect entry to this system, right, is people that are getting medication. And so when we have some different rules, that's certainly one of the first places that we will pursue.
Again, thank you for coming, and have a safe trip back to Tulsa. And this is something that seems completely scalable and something that would enhance better health in Oklahoma. So I appreciate you coming. Members and everybody else, we're going to take a 10-minute break.
I'm Gary Raskob. My day job is as Dean of the Hudson College of Public Health at the University of Oklahoma Health Sciences Center, just down the road. And I have a volunteer role and hat that I wear also as chair of the Oklahoma City County Board of Health. Just one disclaimer for our attorneys in the room. As I am a university employee and that's my main role, I'm here as a public health scientist. I'm going to try and be evidence-based and science-based on these issues, but anything I express or comment doesn't necessarily reflect the position of the university. That would be only done by the president or our senior vice president and provost. So I'm not reflecting university policy, and if you ask me for my viewpoint, I'll give it, but I'm going to really try and take you through some data and science about the social determinants of health. We had a wonderful presentation about some innovations in healthcare and how healthcare is moving to really think about social determinants. I'm going to flip the lens a little bit around and go much more upstream from the time that a person comes to receive healthcare, okay? Because ultimately what I really want to talk about today are the drivers of the health of Oklahoma's population and what we will have to attack or deal with to try and transform that population in a large way and make them more healthy, okay? So if we step back and say, what are the factors that determine our health and the things that contribute to premature death? And unfortunately, something happened in the slide, but I can, in the projection, but I can, you should have printouts too. Great, thank you. You can see that healthcare, which is the blue area, if we were to put in a pie diagram all the drivers of our health, healthcare only contributes about 10%. Doesn't mean it's not important. I'll come back to that later on. But other factors are much more strong determinants of the overall health of our population. Genetics is about 30%. So it's very important to choose your parents well. Right at the moment, we can influence that too much, although science in the future may allow us to deal with gene deficiencies. But for now, let's say we're not able to deal much with genetics. But you can see the big driver, 40%, is determined by behavior, our own personal behavior. Now, about 15% is driven by social circumstances. And then we have another piece, the remainder by environmental exposures, okay? So first big take-home point is that healthcare is not the big driver of the determinants of health of our population. It's the determinants upstream from that. Healthcare is late in the process when a person is sick and has to come and get care. And if we want to transform Oklahoma's health, we have to work much more upstream from healthcare. However, if you're already doing behaviors and other things that predispose you to be ill and other things, healthcare is very important. It can save your life. It does save your life, and it will reduce your risk and prevent bad consequences. So it's an important piece. These are connected, okay? Now, the second thing is, even though behavior is a big piece, social circumstances influence behavior. I'm a big believer in personal responsibility. That's really important. But not all of us start off at the same playing field with the tools to make the right decisions regarding personal responsibility. And so how do we address those issues regarding the social circumstances in our society that don't give everyone the same opportunity to achieve their best possible health? When we talk about health equity, it's really about creating the circumstances for an individual to be the best they can be. We'll never be able to guarantee equal outcomes because of genetics, but let's create a playing field where everyone can get the best for themselves by making smart choices about their behavior and about also the services and other things that we can do and provide. Okay. So this is from an article in the New England Journal of Medicine that really was the forerunner for a lot of what Jennifer just presented. You know, most of the articles that you have in the packet as well were the source material for a lot of this. So you can dig into that if you're not able to sleep at night and you want to have some reading that'll help get you along. There's a lot of in-depth things you can read more about. But here's a quote that caught me, which was by some estimates, more than the 95% of the now more than $1 trillion that the country spends, all public and private funding for healthcare in the United States is more than $1 trillion. More than 95% of that is spent on direct medical services, even though about 60% of preventable deaths are rooted in modifiable behaviors and exposures that occur in our community upstream from healthcare. Okay. So what are social determinants of health? Well, this is I think a nice portrayal of that from the Kaiser Family Foundation. As you heard, these are the circumstances in which people are born, grow up, live, work, and age. They include, under these general categories, is a nice framework for thinking about this: economic stability, your neighborhood and physical environment, education, food, your community and your social context, and the healthcare system. And then you can see some components within those headings, such as, for example, under education, early childhood education, higher education, with regard to neighborhood and physical environment, housing, safety, transportation, under economic stability, income. So in the time I have, and I only want to talk for about 20 minutes or so and have it more interactive, we can't address all of this. So what I've done is, out of my reading of all the evidence, I've pulled out 2 or 3 of these, or 4, that I want to focus in on, which I think are the dominant drivers, or the causes of the causes that we can really, and I'll end up with using those as maybe a springboard for my last slide, just some general policy considerations that you might think about as a committee going forward, okay? So poverty is critical to this. Education and income are 2 things I'm going to drill down into and talk about very significantly. This is Oklahoma County, just by way of illustration. You can see that there's quite a variance in levels of poverty using the standard, federal definition. So, for one person, the 2018 definition was income of $12,000 or less, or $25,000 for a family of 4. That's a very low income level, okay? Well, if you look at this, you can see that the light blue are the areas with the lowest rates of poverty. The medium are the next range, and then the dark blue areas are the zip codes with the highest poverty. And I want to commend our team at Oklahoma City County Health Department. We track outcomes by zip code and have a very comprehensive approach to taking services to those zip codes with the greatest need. And Director Cox is here, and some of the team. But we can look at these zip codes, and if we overlaid this with the life expectancies, some of you may be surprised to know that just in Oklahoma County, the difference in life expectancy between the zip codes with the lowest levels of poverty and those with the worst poverty is 18 years. That's striking, okay? That is like the difference between the United States and developing countries in Africa. Okay, that should not be occurring in our country in 2019. And so we have to get at that and deal with that. Okay. Here's some data about maternal and child health indicators according to these levels of poverty. And you see the pattern is the same for every single indicator: infant mortality, preterm birth, maternal education less than high school, for example, maternal smoking during pregnancy, late prenatal care. Again, for some reason the values weren't projecting, but the message is very clear that across all of those, there's a relationship between poverty and these outcomes, and their outcomes are much worse in the groups with higher poverty levels. So, education. Education, from my assessment of the evidence, is a fundamental cause and driver of our health outcomes. it's interesting, historically, not too long ago, I've been here in Oklahoma since 1991. I've been dean for about 17 years. And I will always remember in the legislative session, in fact, some of the community groups were worried about the higher education budget, and the healthcare community is worried about the healthcare budget, and they're thinking of those things as separate things. And I think we're past that. We need to get past that. But health and education are intricately connected very significantly, and they're not different things. And here you see the relationship, which is bidirectional. So education creates opportunities for better health through a number of ways, but first and foremost, the biggest driver of the job and career you're going to have in your life and your income over your lifetime is your education. And I'm going to show you data about the critical importance of income to life expectancy. Okay. Secondly, education, regardless of how that is with income and independently, gives you the knowledge and tools to make healthier choices. And also some data about that as well. So education is critical to allowing people to make the right choice, the healthy choice about their behavior, whether that's about tobacco, responsible use of alcohol, whether that's avoidance of behaviors of drugs or risky sexual behavior, or whatever we want to talk about. Education is crucial to arming people with the ability to make informed choices. Okay? Now, education income generally will influence very much the neighborhood and community you live in. That's related to safety of the environment, the social capital you can access, the people that you interact with in your life. All of those things are crucial. Okay, we won't delve into in full depth, but fundamentally education is a driver. However, health is also important to education because if you're sick, it's hard to learn. It's hard for kids who are unhealthy to achieve their best in school, and it's difficult for people who are ill and disabled to be effective at work or even work. Even if they don't meet the full criteria for disability, they may have levels of impaired health that really lead to absenteeism, ineffectiveness, depression, mental health issues, very important as well. Okay, so there's an iterative process. Education is critical to all of this, but the contextual factors, the social circumstances, individual and family characteristics, and the social circumstances we live in will influence whether people are able to get and receive education, and that's important also. And the education they receive from their parents, also important. So this is not only about formal school education, but role modeling, mentorship, various other types of education that are less formal. Well, this is the data from the Robert Wood Johnson Foundation. This just shows on the left side in 2012 unemployment rate, and on the right side median weekly earnings according to your level of education, with a doctoral degree at the top and then progressing down through professional degree, master's, bachelor's, associates, some college, high school diploma, and then less than a high school diploma. I think the message is clear. Much higher unemployment rates and lower incomes among individuals with less education. This is going to be fundamentally crucial for the future because we're in a time where jobs are in transition, careers are in transition, technological advances are going to lead to displacement of people from various careers. I listened to a very interesting presentation by one of these future prognosticators who looks at demographics and various things, and the statistic that was striking is that a child born today, 2/3 of those children will work in jobs that are not yet invented. Education will be fundamental to arming people with the tools for lifelong learning and critical thinking and the ability to be able to adapt and transition as economic conditions change amongst different industries. And we are seeing that a lot right now in our country in terms of how different segments are having a challenge, and how globalization is affecting us and how we respond to that with respect to disruption in these careers, right? So education's crucial, and the message here seems to be clear that the cut point at which we're really making a big difference now for the future is really going to be some level of post-high school education. A high school education is not going to be enough to give you the tools for survival in a good way in a future society over the next 20, 30 years. Not everyone needs a PhD. I think vocational education, for example, and with the weather we've had, if my air conditioning went out today, I'm useless, as my wife would quickly remind you. But, you know, those careers, vocational careers also that have good jobs and sustainable good jobs, coupled with retraining and ongoing continuing education, is going to be a pathway, and that's going to influence our health. There's no question about it. So I said education is a big driver of income. Let's look at this. This is a really an excellent study done by Stanford University, Harvard University, in collaboration with the United States Tax Center. And what they did is they reviewed tax returns for 15 years over the period of 2001 to 2014 and linked those tax reported incomes to other databases on life expectancy and self-reported social behaviors like smoking and drinking and various other things. Here we're just focusing on income. And there's a couple key messages. So on the vertical axis, you see the expected age of death for a 40-year-old now. So this graph shows people who've survived to 40 years of age. Now, how long will they live from 70 up through 90, based on the horizontal axis, the percentile of their household income across the country, okay? So 20, 40, 60, 80, 100th percentile. But on the just below those percentiles, you can see the mean household income. So we're going from about $25,000 for a household under the 20th percentile. Quite interesting that over this time, 40% in the United States of people in the United States made less than $50,000 a year. That's pretty striking in today's demands. But you see, we go from about $25,000 a year for the 20th percentile out to, at the 80th percentile, $112,000 to $119,000 for our women representatives and senators here. Yes, it's wrong that women are paid less, and we'll continue to work on that. But at every level, you can see the result was a little bit lower. So, few messages. There's a continuous and ongoing relationship between increasing income and increasing life expectancy. And it doesn't even plateau up when people get to $100,000. There's a change in life expectancy for them, not as big, but a change even out to $1 million. So there doesn't seem to be a plateau on this income effect. Income is really crucial, but look at the difference. We're talking about for women a life expectancy in the early 80s up to almost 90, and for men, we're down at 75 up to the high 80s. At every level of income, life expectancy for men was less, but that gap is much more pronounced at the lower incomes, right? But as you get up to higher incomes, we sort of equalize that. And then if you look at the difference between the bottom 1% and the top 1%, that's about 10 years. In case of women, it's 10 years of life expectancy. In men, it's 15 years. 15 years of life expectancy. This is a big, big driver. Okay, income is crucial. Education determines your income by and large. Now, another interesting finding, this shows the sort of same graphs. They've changed the horizontal a little bit to talk about ventiles at 5 percentage point increments of income. That's okay. Same vertical axis in terms of 40-year-old getting out to 70 or 90. Now, and on the left-hand side is men, and on the right-hand side is women. If you go up to the high ends of income, right, we see that these lines for different cities are all pretty much overlapping. But where you live makes a big difference when you're down at lower levels of income of around $30,000, $40,000 or less. And the differences between New York, San Francisco, Dallas, and Detroit are quite significant. We could talk about or speculate why that is, but where you live makes a difference. The influence of environment, the services available to you at the low income segment of this data. Now, one more thing, I think I like to have some encouraging points, and this graph gives, or this table gives some very good encouraging news, because I'm sure like you, I'm tired of always saying, Oklahoma ranks in the bottom 10 of this, and we're always on the bottom on every indicator, and we always have to keep saying that, and thank God for Mississippi, right? And so on the left-hand side of the graph is the bottom quartile of income, and on the right-hand side data is the top, and the numbers are small, don't worry about it so much. Here's the point. They've ranked the cities in terms of life expectancy, and you see the top 10 and the bottom 10 for each quartile. Low quartile on the left, top quartile on the right. Look where Tulsa and Oklahoma City are. We're down at like 96 and 98 in the ranking of life expectancy. That's worse, bad life expectancy, at the low income bottom quartile. We don't appear on this table for the top quartile of income. That tells me if we get education and income up in our population in Oklahoma, we will again realize those benefits. We're not in this bad data for our people in higher incomes, okay? It's not something special about Oklahoma that we're always in the bottom. That when we do that, and when we look at our people with better incomes, and when we look at better incomes across our zip codes, we're clearly not in the bottom 10 anymore. We're not in the top 10 yet. We need to work on that, and there are reasons for that, but we're not in the bottom 10. All right, let's switch gears. Tobacco, very important. I hope you're not tired of hearing about it, but I'm going to keep pounding on it because it's the most detrimental thing to our health that we can have. So this is just a graph that shows the survival probability for smokers or never smokers. On the left-hand side is the graphs for women. On the right-hand side is the graphs for men. The vertical axis is the probability of surviving. It's a probability of a 25-year-old surviving to those ages, okay? And going up, so in probabilities, okay? And on the vertical, horizontal axis is the age gradient, so 30, 40, 50, 60, 70, 80. So it talks about the probability of a 25-year-old living to 30, 40, 50, 60, 70, whether they smoke or don't for women and men. And the message is, look, the probability of a woman, 25-year-old woman, reaching 80 years of age, if you don't smoke and never smoked, is about 70%. But it's only 38% if you're a smoker. And those curves drop off very steeply, right? Which means that smoking is contributing enormously to premature death. And on average, smoking will take 10 years, overall 10 to 12 years off of life expectancy. There is no treatment, surgery, procedure, anything at the Stevenson Cancer Center or the Integris Cancer Institute, anything that'll have more effect than getting people not to smoke, okay? And so it's really crucial. So, okay, well, Raskob, what does that have to do with social determinants of health? Well, guess what? People with less education smoke a lot more. Oklahoma overall, 20% smoking rate, but it's not the people with undergraduate degrees or graduate degrees where the smoking rate is 4 to 7%. Maybe there are smokers in this room, probably the majority are not. But it's our people at low socioeconomic status, high school graduates or less than high school, where we have a 36% smoking rate. And tobacco companies target advertising towards those people very aggressively and clearly. There's no question about that, okay? Secondly, we can do the same graph by income. Income is really the intermediary after education, so less than $35,000 a year, 21% smoking rate. The people who can afford at least to waste $10 to $20 a day on something that's markedly increasing the probability it's going to kill you are paying more, and that is having a big impact on the health of our population. So I want to come back to, we have to target tobacco, but in a more selective way at the lower socioeconomic status groups. Housing. The article I gave you, there are more than 25 studies that are relating the importance of housing to health. And so I've chosen education, income, tobacco, housing, because those are ones with really strong data and evidence that would support policymaking actions that you might want to do. So here, housing, we can think in 4 domains. Stability of housing. Are you sure you're going to have a place to live? Are you being threatened with eviction or foreclosure of your mortgage? Quality and safety of your housing. Are you living in a place where there are toxins, water leaks, poor ventilation, dirty carpets that foster pests, cockroaches, other pests? And temperature is very important. In these kind of temperatures we've had over this summer and this last while, elderly people who may be dehydrated, who don't have adequate adequate cooling or other things, are at risk of bad health outcomes as well, okay? Regarding the stability, the threat of always losing your place of residence leads to depression, suicide, alcohol use, more smoking, higher Medicaid costs. The evidence is clear for that. Housing is related to Medicaid costs, there's no question about it, and higher emergency department use. Okay. Affordability. If the housing is not affordable, if the people are barely making ends meet to keep the roof over their head, then they forego needed medical care or medications, and they have insufficient or unhealthy foods. And you heard from Jennifer that validated. They inquire among those patients when they see them, and then they learn they have lots of needs, and they can't meet all those needs because they don't have adequate income. And then your neighborhood. The neighborhood, do you have a safe place to exercise and play? Do your children have a safe place to go outside? Do you have access to public transportation? Because if you're living on $20,000 a year, you're probably not having a car. And, can you get to and from work easily? And do you have a safe route to school? And interestingly, even in 2019 in the United States, air pollution is correlated with increased mortality. And there's good data that the quality of the particulate air relates to increased mortality amongst Medicare participants at low socioeconomic status. Okay? It's not a big driver as some of these other things, like smoking, but it is relevant. Okay? So housing is very important, and at least providing some stable and safe housing can influence and improve health outcomes and lead to reduced utilization of Medicaid, for example. What about health insurance coverage? It is important. So what do we know about this? And I'm staying broad with health insurance coverage. I'm not talking about a specific type of coverage. But this is a summary of the evidence from Professor Summers. I've given you the article. I think it's a very good summary of all the literature on the impact of health insurance on health outcomes. Not on can we keep rural hospitals open or can OU Medicine make revenue, all of that, but actually does it influence the health of our population? Okay? Well, it does. First of all, and it has other benefits. It's clear that people who get health insurance coverage have improved financial security. There's less catastrophic spending, less out-of-pocket spending, less bills sent to collection, and less credit, and a better credit score, and less bankruptcies. And you've heard this before. Unpaid medical bills are a major cause of bankruptcy in the United States, personal bankruptcy. Access to care and utilization. People with coverage use more outpatient care. They have a usual source of care, a physician that they can see. There's more preventive visits and preventive care. They have better adherence to their medications. They can access surgical care. Surgery is important often, but you need a way to pay for that. Interestingly, there's mixed results on whether they use the emergency department less. Probably because there are people who need to go to the emergency department who don't go because they can't pay for it. There are a lot of people who go because it's the only place they can go, and they use a lot of reasons. So we're losing on both sides of that one, okay? Chronic disease care and outcomes. People with coverage get more diagnosis, treatment. They have better outcomes on depression. Mixed data on whether we detect cancer at an early stage. That's probably because it's pooled data for cancers. But if we look at specific cancers like breast and colon, it's pretty clear that if you can get a mammography, if you can get a colonoscopy, you have a way to pay for those things, you're going to have better health outcomes. We're going to save lives. There's no question. But if you can't get that, you're going to come with advanced cancer that has a bad prognosis. Better well-being and self-reported health in most studies, and mortality. The best evidence comes from studying Massachusetts, who was very similar to Oklahoma. At the time, Massachusetts, under Governor Romney, moved to create universal health coverage for the state. They had 15% uninsured, and they went down to 2%. Oklahoma's now at about 14%, right? So the data from that 5 years on showed that the provision of that coverage led to a 3% absolute decrease in the age-adjusted mortality in the state. This was larger if we specifically looked at healthcare mortality, healthcare amenable mortality, right? Because providing someone health insurance coverage isn't going to reduce necessarily deaths from motor vehicle crashes or gun-related injuries and deaths or other things, right? So if we specifically focus at deaths that would be amenable to health care, the kind of thing I talked about, mammography, colonoscopy, pap smears, early screening for cancers, early diagnosis and treatment of those things, getting your blood pressure measured, getting your cholesterol measured and treated, all of those things, the benefit is even bigger, such that we could say that if we take Oklahoma or Oklahoma County or the state, for those who are uninsured now, for every 800 people that we would provide some form of health coverage for a year, we would prevent one premature death. And that's pretty strong data there. Data from Arkansas suggests that they didn't expand Medicaid. What they did was they created a subsidized private option. It seems that you can obtain all those other outcomes that way as well. There's not as much data on the mortality, okay? But the message here is get people covered somehow, and we will improve their health, and we will prevent premature deaths. As health systems are increasingly being held accountable for health outcomes and reducing the cost of care, that's why CMS is providing these pilot grants to what you heard before. These health systems need tools and interventions that address patient community and factors attributing to excess utilization. Much of the focus from CMS has been about, can we get that small group of people who use a lot of healthcare to reduce costs? I think our purpose should be much bigger. My purpose is about extending life, preventing morbidity and disability, and improving health outcomes by getting coverage. It's going to require effective partnerships. Now, the kind of projects that Jennifer was talking about, there's many of those, and in the readings I've given you, you can look at some of the tables, and there are examples of things that are happening in other states, really interesting examples that would be worth us looking into in a little more detail, okay? These are all based on partnerships between medical care, existing social services, public health, health departments, and community-based non-governmental organizations. And what's the way that we can get them working together to support these kind of efforts? And how do we provide the funding to make that work? That's why CMS is looking, because they will think about changing their payment model from just paying the hospital for some service to paying a accountable community to achieve a certain health outcome. So partners in the system, partnership is critical. Partnership is a core value of public health. It's a core value of the Oklahoma City County Health Department. Are listed: healthcare delivery system, community NGOs, the governmental public health infrastructure, and you're going to hear from Buffy, also a very important partner in this, business in the private sector, academia, not just higher education, but the complete spectrum of education is really important. But if we only invest in early childhood and then don't take care of things later, I would pose that we're wasting our investment. And media is very important in getting information out to people about in an accurate way. So this is an example of an innovative project that the Oklahoma City County Health Department is engaged in partnership with an integrated care team with OU physicians and with community health workers, social workers, and public health nurses. And so this is really targeting social determinants and at-risk youth. And you have heard that the Oklahoma City Public Schools went through quite a challenging situation this year where they've had to make some hard decisions about closing schools. They had schools that were 50, 60% capacity, and they had to make some hard decisions about consolidating and make, well, we've partnered with Oklahoma City County Health Department has partnered with Oklahoma City Public Schools and are taking 2 of those closed schools, repurposing those into providing a space and a community center for connection to social services and for targeting programming at high-risk youth and their families. And they will get a variety of type of services and mentoring and education, various other things in those repurposed schools. And those 2 pilot ones here, and this could be scaled, I think, Sequoia and Oak Ridge are in the 2 most poor zip codes in terms of health outcomes. And so we're taking the services out into the community, and I think that that's an important theme for where we're talking about health in the future. It's not all going to happen from a person coming to a clinic or a facility. We have to go out to them where they are. And it's not all going to happen by doctors. There's going to be a very important role by other health professionals, nurses, pharmacists, but even people at a lower level, and the community health worker, who's a person maybe with a 2-year degree, maybe less, who's trained on key things, who is there for regular touch with these patients going forward to help them navigate access to various services. It's the kind of thing that Jennifer was talking about, but in a little bit of a different model where it's not the hospital or the health system necessarily, but it's our, in this case, health department and other partners managing this. So we're really excited about this project. I want to commend Director Cox and his team for their leadership in partnering with Oklahoma City Public Schools on this. I think this is an innovative approach. We're going to learn whether things like this, targeting the social elements far upstream from healthcare before these young men and women are getting into substance abuse or alcohol or other things, or practicing risky behaviors, okay? All right, my last slide is my suggestions for general, based on the evidence I talked to you about, some general things that could be addressed. You're the legislators, how you do it, up to you. I'm just talking about big themes where we should be working, okay? We must continue efforts to reduce smoking. We commend the legislature for the efforts, the last increase, but that was really done as part of a budget deal, and the focus was on filling a big budget gap. I would like us to shift the emphasis from thinking about smoking as a revenue issue to a crucial issue in improving the health of our population. And guess what? The revenue is a twofer. So we need to target, though, what we do. So the best way to reduce smoking by far from the evidence is an increase in the tax of cigarettes. But let's take some of that revenue and put it back to enhanced prevention and cessation efforts for the people who need it most, the low socioeconomic status groups. And that takes away the criticism I've heard. That makes it a non-regressive tax. That makes it a way to bring help to people who, because of their social circumstances or education, are smoking. They weren't armed with the knowledge, or they are smoking as a way to alleviate, self-medicate the circumstances they're facing. But let's bring enhanced prevention and cessation to that group, which is not running at our average 20%. They're 36% smokers, right? And if we drive that down, we will for sure, in a reasonably short time, we have evidence at Oklahoma City County from the Wellness Now program, over a 3-year period, you could see hard outcomes changing. Cardiovascular deaths, lung cancer deaths, other things. And we should monitor those, we should evaluate those things and report back. But I would strongly urge you to consider further work on this. It's not one and done on tobacco because we made a $1 increase, okay? We absolutely have to find a way to increase the proportion of people who get a post-high school education. That could be vocational, that could be a 4-year degree, could be more, but vocational or a 4-year degree for the future, for the jobs of the future, to arm those people with the knowledge they need, we absolutely have to increase our population who get that education. How we do that is the challenging part, but we must do it, and it will pay large dividends back. We need targeted programs for affordable quality housing for low income and individuals in poverty, and there are some innovative processes going on where health system funds or other funds are being used to help support these kind of things, and they're evaluating the effects and find that these will actually translate to good ROI in reducing healthcare costs and improving health outcomes. Housing has a lot of data. Look at the article I gave you. It's a very well done brief of more than 20 some odd studies by the Robert Wood Johnson Foundation. We have to incentivize partnerships between health systems, public health departments, and NGOs to implement routine screening for social determinants, the exact thing that Jennifer was talking about. Okay, but we need to find a way to optimize that, to evaluate it, and to make it sustainable, because what are they going to do when the CMS grant goes away? How are we going to sustain that? How are our payment models going to support these kind of things, which are critical? So I've advocated we got to start on social things way upstream, but we should continue addressing those as people do come to the healthcare system, okay? And then finally, we need to expand health insurance coverage for the low-income population. From my perspective, I would just like to see that happen. Whatever the mechanism, it'll be fun to listen to your debate on that. I think, we need to do that for sure. It's very clear that, and frankly, I think people, if they can access health care, then they can get preventive services, they can get other things that are going to improve their health outcomes, that are going to prevent premature death. So with that, I'll stop and say thank you. It's been a pleasure to be here. I appreciate the opportunity. We're happy to answer any questions you may have.
Thank you, Dr. Raskob. You gave us a lot to think about. We appreciate you taking time out of your day to come and talk to us, and we appreciate your thoughts and your recommendations. Do we have any questions for Dr. Raskob? Yes, Representative Lawson.
Thank you, Mr. Chairman. Thank you so much for your presentation, Doctor. Just looking at one slide that said behavior patterns is 40% of premature deaths, and then the quote from the New England Journal of Medicine saying that 60% of preventable deaths are rooted in modifiable behaviors and exposures. I'm just curious, in your research, is there any findings to suggest that one circumstance, whether it's higher education or it's higher income or safe neighborhood, is there one of those, or is it truly a combination of all of those that lead to behavior change? Is it simple health insurance, or is it something else altogether?
I think it's for sure a combination, but different elements have different magnitudes, right? And so just to illustrate that, if we go back, again, if all of us were to say, you get to pick one single thing to improve your health, is that exercise? Is that diet? Is that something else? The single most biggest impact would be to choose not to smoke, right? For sure, by far. And then diet, exercise, everything else would come along. So education driving income, income driving your employment, the likelihood you'll work for an employer who has health insurance for you, your knowledge about making choices of these behaviors. I think education is a critical driver, but arming people with the decision. You see 36% of these people are smoking, and that's going to give them a life expectancy that's 10 years less, right? So tobacco for sure, and if we change everything else in Oklahoma, but we don't address tobacco, we're not going to be capitalizing on what we need to do. On the other hand, access to healthcare is very important, as I pointed out as well, because we can't just, there are a lot of people who have needs right now, and we can't just write them off and say, well, it's all about the future now. You know, and that's the challenge really for government, isn't it? Finding a way to deal with those people who need care right now because they've lived through social circumstances that make them ill. But with care, we can prevent the progression of disease, we can prevent bad consequences, we can do other things. But we have to shut off the pipeline of increasingly unhealthy people coming into our healthcare system. And that's working here on upstream on social determinants. But which things have the best evidence? Education, income, transportation, those things, because you're going to have to prioritize, and you don't have unlimited resources, and you can't do everything all at one time. That's why I focused on those things. But environmental exposures, other things are important. Okay? Good.
Dr. Raskob, I don't see any more questions. You did a very thorough job. We appreciate you coming. We appreciate all of the extra resources that you gave us for homework. And so, members, we're just going to plow through this. If you need to take a break, you can get up as you want, but we're going to go ahead and plow through.
Can I mention, by the way, just
yes.
is that from my perspective, the conversation doesn't have to end, you know, because of this thing. If Jen has my contact, chairman has my card. We at the university are always there to serve and be subject matter experts for you, our legislators. Do not hesitate to call. Okay.
Thank you for that offer. I'm sure we'll be using it. Thank you. Okay, let's move to Teresa Huggins with Stillwell Health and Wellness Center. Is your green light on?
Okay, now can you hear me? Okay, usually I don't need a microphone. I am Teresa Huggins, and I'm with the Stigler Health and Wellness Center, Stigler.
Thank you for that correction.
So definitely, we're not as far north as Stillwell is.
Yeah.
So does anybody need, I've been asked to lead some yoga because I'm at the critical point in the afternoon where I know everybody's heads are drooping. So I'm going to try to keep this lively. Yes, okay.
That was a joke.
So I'm also thankful that Jennifer and Gary went before me because they really covered the data, which is kind of boring. It's great data and you need to know it, but now I get to give you my perspective from boots on the ground in a health center trying to address these things. So some of my presentation I'll kind of gloss through because I wasn't sure about what they were presenting, so it's kind of the same data. Some of it is. But first of all, there are a lot of new faces in the room to me. My reps are not in here, so I'm glad that I was asked to speak with you all. I appreciate it, and I'm glad to see the new faces. With that, I don't know if you've been told a lot about federally qualified health centers. Now, my reps have had it shoved down their throat because they've been listening to me for the last 14 years. But like I said, there are some new faces here. So I wanted to let you all know who's running. Oh, I'm running the mic. Okay. What an FQHC is. FQHCs are federally funded community health centers. And we're a division of the Department of Health and Human Services under the HRSA Resource Service Administration. So FQHCs are funded federally with an initial startup grant, and then we take that grant and we build from that. We provide comprehensive, high quality, and cost-effective health care to anyone regardless of their ability to pay. So the grant money that we get has to be spent directly on services. Cannot be spent on bricks and mortar. Has to go direct services to low income and uninsured people. That means that there is some accountability on our patients' part because they're charged a sliding fee scale if they don't have insurance, or if their income is low enough that they qualify for that. We're even sliding their copays. So even some people that work 2 jobs and happen to have insurance that are scraping by on income can still get a discount. So there is some accountability there with our patients. It's not considered welfare or free health care because the patient is still responsible for their part of the payment. I just talked about the personal responsibilities. The last thing I wanted to mention about community health centers are that we're community owned. So we can't go into a community unless they want us to come in and provide services. We are all located in health professional shortage areas with medically underserved designations. So we have to be in a low-income area. Our board of directors is volunteer boards, and they can be from 14 to 25 members, but they do make up 51% of our board is patients of our health centers. So they must be our customers is what they are. So over half our board is. The next slide just gives you an idea of where community health centers are in the state of Oklahoma. And I think this says there's 89, but now there are 96 sites. You can see exactly where we're located, and 83.5% of the population in Oklahoma is within 30 minutes of a community health center. So we've got a pretty good overlay. When you overlay low-income populations and our zip code data, it almost fits perfectly over this map. Our general population that we serve is a majority uninsured and Medicaid population. So we do have about a 0.25% of insured patients across the state, and then 11% Medicare. Each center varies a little bit. I think our Medicare is about 15%, and our Medicaid's about 38%. So each health center varies a little bit, but this is just kind of a statewide overall look at the patients that we serve. Mention that we're required to see everybody. The patients with incomes between 100 and 200% of the federal poverty level pay on the sliding fee scale, and 100% have a nominal fee. So. Let's see, I want to go back. I think that I might have sent this before I made the last edit, but the last edit I put on there was that health centers serve over 220,000 patients in the state of Oklahoma, over 700,000 visits in the state of Oklahoma. So it's a pretty broad network. I'm not going to tell you I was up at 11 o'clock finishing this last night, and Ms. Tups only got it this morning. But so the average cost to serve a health center patient for a community health center is $764 per year. That is medical, dental, and mental health. We have optometry and pharmacy. So we are definitely, we have diverse services for the patients. A recent study in the American Journal of Public Health verified that total Medicaid spending on health center patients was 24% less than non-health center patients, and 25% fewer admissions are from community health center patients. So I'll kind of get into that, and it falls right along with the social determinants of health that Jennifer and Gary spoke about. So for every $1 that an Oklahoma community health center spends on patient care, we save the state $1.65. Overall, $278 million saved at the annual cost savings rate of $1,263 per patient. That takes into account total savings. So it's $674 costs per patient per health center, but $1,263 savings across the total system. So if you include hospital, ER, that home health, those other type things, you can save $1,263 per patient. So we do this by using patient-centered medical home model, and it's going to, like I said, just tailor right in to the social determinants of health. We bring the services to the patient. We meet the patient where they need to be met, where they are. So my health center I've provided a map here. We're over in the eastern part of the state, and I'm missing a dot. We've got 7 locations now, but we were established in 2005, and we have about 27,000 patients, 34 providers, over 200 employees. So just wanted to give you an idea of some of the data that I'm going to be sharing with you today is from that perspective. It's kind of a regional presence. About our services, wanted to give you an idea of the range of services: medical, behavioral, dental, optometry. You can see that we do everything from preventive to acute care and preventive behavioral health, dental, optometry. We do exams. We're tying these things back to diabetic retinal screenings. So everything is tied together, and it's going to culminate through the social determinants of health. The next page shows that the pharmacy, and I think you said Representative Marty was on the phone. I hope he's still listening, because I wanted to say that the prescription medications that we're linking patients through our pharmacies are provided at the 340B discount rate. So some of the patients that come through with no insurance that are connected to these very expensive medications can receive them at up to 60% off of the retail prices.
Can you quickly just summarize? We haven't talked about the 340B program at all, and I don't think that many members know what it is. Could you tell them real quick?
Sure, absolutely. As a federally qualified health center, we are deemed eligible through having our federal tort coverage and all the regulations in becoming an FQHC. We're eligible to purchase drugs at it's almost like the VA pricing. It's at a very reduced cost. So in my main location, which you guys saw a picture of, we have a pharmacy that we operate in-house, and we purchase the drugs and dispense through there. Now, we also contract with 14 other pharmacies in other communities. So you can do a community health center can do this in-house, or they can contract with local mom and pop pharmacies. They can contract with Walmart. They can contract with Walgreens or CVS. Basically, the community health center is the deemed entity for that discount. There's been a lot of scrutiny at the federal level, because a few years ago they made some changes to the guidelines, and they've picked up on some misuse or fraud and abuse. So just want to get this out of the way. That was not with health centers. And we've been pretty vocal at the federal level. We were hoping in their efforts to fix that, that they did not just take a broad brushstroke across the whole program, because it's detrimental to our patients. It is huge. It is a huge part of what we do. The medications can make or break the diagnosis. If a person goes to the doctor and they can manage to scrape up the $20 minimum fee, which is about average for the lowest fee possible in a health center, about $20, they can't go and pay $260 for a prescription. So this program it's just crucial. I'll answer any specific questions on that as we get to the end if you want me to, but I hope that was a good enough explanation for it. So you can see the other things that we do. Medication counseling. We're starting the diabetes self-management education. We have the laboratory services. We do some CLIA-waived in-house, and then we contract with local hospitals in our areas for other stat labs and x-ray services. Telehealth is also huge. We're currently doing medical exams, counseling, crisis intervention, and health education with 10 small rural public schools, 3 of the junior colleges, Connors, Carl Albert, and Eastern, and then 3 of our local correctional facilities, so LaFleur County, Haskell, and McIntosh. So we're providing medical and counseling visits for those entities through telehealth upon their requests. So I had a statement, and it looks like a paragraph, but it's one sentence. It's a long one, but I thought it was pretty important. A patient from a health center in Ohio who was implementing Prepare walked 20 miles barefoot at night to escape a domestic violence situation because she knew the behavioral health nurse who had helped implement Prepare with her and helped address some of her needs identified by the Prepare would help her again. So when Jennifer mentioned the domestic violence information coming out of it, it's huge. And most of my data I took from the National Association of Community Health Center website. So this is looking at it a little bit from the national perspective. It's everywhere. They've been through what social determinants of health are. I don't think I need to rehash that. Also, the same exact chart that both of them had is showing how much the determinants of health can affect. So I had a talk with my providers, and I said, I realized that the clinical care piece is only 10%. But, I mean, think of the impact that we could have if we could make a 10% difference in the social and economic factors, or if we can make a 10% difference in their health behaviors through partnerships with the health departments and your policies and procedures, and the physical environment. If we could make small strides in each of those, then the cumulative effect would be huge. So that's kind of what we took on at our health center and other health centers across the state and the nation, was to try to make those differences with our population. Yep, I see people taking pictures of that slide, so I'm going to leave it up there if you want. Or you can get the presentation. I'll be happy. So Prepare is the tool that is being implemented through community health centers, and that's the protocol for responding to and assessing patients' assets, risk, and experiences. Like Jennifer mentioned, that screening's over 20 questions. So when they took it to people and they said, we don't have time to do that, it makes me want to tell them to slow down and go back and look, because when we implemented the Prepare, 13 questions were already in our demographics. So we really only had to add 7 questions to our patient check-in process. Like Jennifer said, we're doing this through an electronic means, and right now when you come into our health center or when you call for an appointment, we are texting a link for each person to pre-register, so they can do it from their phone and they'll answer all those questions from their phone. Or when they get to the health center even, they're handed a, so we call it the Freesia pad, because Freesia is the company that's helping us coordinate that. But anyway, they enter it on that on the Freesia pad, and that goes directly into their health record. So not everything's crossing over yet, but we're working on it. It's improving. These are being able to screen, and when we screen these people, it's notifying what we've put in our health center. We call them integrated care specialists, and they're bachelor's level case manager type employees. They are integrated on our medical floor with our nurses. So if somebody scores high on a depression screening, a suicide screening, or if they ring the bell on the social determinants of health, that person's notified. We need a check-in in exam room 3B or whatever it is. So that person goes in, and once again, we've found out, we've found a lot of domestic violence in those situations that was not being answered or told, just by going in and making that face-to-face contact and getting them to know that we're there to support other needs. So it was a national effort to collect and apply this data. That data that goes in to our system is linked to ICD-10 codes. So we can actually even get more data as to what chronic conditions are related to which social determinants of health for future planning and proactive efforts. Some of the things that we can do, and you guys have heard the AHC, the state had the SIM model. Those are state initiatives and federal initiatives. And then the provider level ones are what I'm talking about for community health centers. It's the PREPARE. So these actually, on our level, allows the provider to define and document, like I said, the chronic conditions and the complexity of the patients. That in turn allows us to better target their clinical care and what enabling services that they need to have good outcomes. It's driven us really to develop more partnerships to address the needs of our patients. And it also has given us a way to demonstrate the value that we're bringing to patients, communities, and payers. So this gives us really some pretty solid data on advocating for fair and equitable reimbursement, because right now my integrated care specialists are not reimbursable services. So I have employees doing this that I'm not getting paid more for, but yet they're making a really big difference on the back end, on the savings side. So yeah, it just gives us some data to advocate for change at the community, state, and federal levels. When we implemented this, things that we figured out were it's pretty easily administered. It can be given by anybody. If someone can't do it on the electronic means, just about any staff member or layperson can help someone take it. Like I said, the data collected and it goes into our EHR and it's linked to the ICD-10 codes. Now from there, HRSA pulls all of our codes up through a yearly report we call Uniform Data System, the UDS report, so they can actually pull it up and get national data on community health center patients. The staff find it helpful to know what our patients' needs are, other than just do they need a pill or do they need a shot. They're finding it helpful in addressing the overall person, and the patients they appreciate it. So it's identifying new things that our patients are needing, and it's definitely led to positive changes, more partnerships and collaboration. So the general population of health center patients face approximately 5 out of the 20 questions of the social determinants of health. They usually check mark 5 of those. That's a lot. More complex patients face upwards of 10 social determinant risks. And I thought it was very interesting that the diabetic experience a greater number of social determinants than diabetic that has uncontrolled A1C. So someone who has a controlled A1C and someone who has an uncontrolled A1C could be the difference in paying their electricity, could be the difference in their refrigerator not working for their insulin. All those things that we don't think about from that perspective that affect that person's health from home. If I don't have a fridge, I can't keep my insulin cold. And asthma and mold and anything in that realm as far as breathing and COPD. So there's a positive correlation to the number of the social determinant risks a patient faces and having hypertension. So I'm pretty sure that if I'm homeless or can't afford my utilities, I'm going to have high blood pressure. People being able to afford their medication obviously affects the many different clinical diagnoses. It affects the stress levels, and that also drives up hypertension. The 5 most prevalent social determinants of health risks from 2015 to 17 were high school education, less than a high school education, no insurance, stress levels, unemployment, and limited English proficiency. So health centers are required by federal statute to require translation services for any patient. So we do have to provide culturally appropriate services in each of our locations. So like I said, all this data that we gather develops, it helps us develop interventions and form the community partnerships. It gives us the data to address population health management and advocate for the upstream changes that really trickle down and affect the long-term health. And we can inform policy and have informed policy and develop adequate reimbursement with the data to show the savings in the long run. So that really kind of concludes my PowerPoint presentation. If you have questions, I'd be happy to try to answer those.
Thank you, Ms. Huggins, for that. And sorry for calling it Stillwell. It is Steigler.
That's okay.
And thank you for educating us on federally qualified health centers and the 340B drug program. Those are all important, very important spokes in the wheel for our healthcare. So we appreciate it. Do I have any questions from any of the members? No? Okay. I will give them your email and all of that. I'm sure questions will pop up. Thank you again for taking time out of your day to come and talk to us, and we appreciate your recommendations and your comments.
Thank you so much.
Ms. Heater, please introduce yourself and do what you do with public health.
Absolutely. Thank you very much for having me back here again. Buffy Heater. I'm the Chief of Data, Public Policy, and Health Promotion at the State Department of Health. What I'd like to do today, very briefly, is from the State Department's perspective, kind of bring all of this home, if you will. So I'm going to start out by bringing back this slide, not because I want to belabor it, but because I want to draw some conclusions, because I recognize that you all as members have heard a wealth of information today on what social determinants are. You've heard exhaustively from Dr. Raskob about the importance of social determinants as we're looking at burden of disease across Oklahoma. And so what I'd really like to focus on today is to call your attention to the 4 chronic conditions that I mentioned to you the first time that we met, those being cardiovascular disease, cancer, diabetes, and lung disease. Out of those 4 conditions, that is the cause of over 65% of all deaths in Oklahoma. So what I'd like to do for you today is rather quickly go into a deep dive of the data to present to you what the social determinants around each one of those diseases look like amongst Oklahoma's population. So each one of the slides that you're going to see is going to have the same color scheme, and many of the trends are going to be the same. So bear with me as we kind of get oriented to this. What you're seeing here is the state of Oklahoma data, Oklahoma-specific data according to the Behavioral Risk Factor Surveillance System for adults in Oklahoma. So these are adults that have been actively, that have responded in this survey, that they have been diagnosed with high blood pressure. What you see here is of those folks that are responding, yes, that they have high blood pressure, here's what their demographics look like specific to this burden of disease. So you'll notice that the majority of people in the purple column are trending towards the older age ranges. And so as a person advances in years, so does their probability that they are going to be diagnosed with high blood pressure. The green columns are indicating that educational status that I believe all of our presenters before me have talked about. And so you'll note that as educational attainment increases, so as you see, we go from less from high school plus some post-grad, as well as a college graduate, that arc is going downward. So the prevalence of folks that are saying that, yes, they have high blood pressure or have that diagnosis as they have more advanced educations is going down. Likewise, whenever you look at the peach-colored category, this is correlating to that individual's income level. So you'll notice that individuals that indicate that they're earning less than $15,000 a year, they are the group that has the highest response rate in terms of actively having high blood pressure, right? So again, that trend line comes down as a person earns more, the lower their probability to be responding that high blood pressure is affecting them. We have somewhat of a potpourri, if you will, of any diseases that may be showing up across any region of the state. So one of the common factors that you'll see here is that we don't see just one region of the state that seems to have a problem with disease X or disease Y. These are elevated rates across all areas of our state. Then the last column on this particular slide that will be repeated is it gives you the snapshot of that individual's insurance coverage. So here you'll see that folks that are responding that they are uninsured or have no source of insurance appear to have a lower rate of saying that they've ever been diagnosed with high blood pressure. One thing that this group needs to recognize that a potential reason that you may see lower rates is not necessarily because that disease is not as prevalent in an uninsured population. Instead, what I would suggest to you is that it may be that because of that person's lack of access to affordable health insurance, it could be that those individuals have gone undiagnosed. So you'll see this data element on the slides. It may seem a little backwards, and as you've seen in previous presentations, we might understand some of the factors that might be at play on that data point. I'm not going to go through each slide with that much detail, but I will point out here that many of the trends are the same. So this is portraying now adult hypertension. So again, purple, as an individual gets older, the higher are their chances are that they will be afflicted with hypertension. You'll notice that slight downward shift as in the green and the peach areas. So as you have higher educational attainment, you're achieving greater than the state's median income in terms of an average salary. Those are corresponding to reductions in the prevalence of the disease. And then fast forwarding over to heart disease deaths. So when we talk about all of the factors that have been at play, you'll remember on my first slide, the 4 chronic conditions that we're talking about: cardiovascular disease, cancer, diabetes, and lung disease. How that equates to deaths is that you see the majority of the population, at the end of the age spectrum. I won't call them older adults, but at the end of the age spectrum, you do see that heart disease is a major contributing cause to early and premature death among Oklahomans. So let's take a little bit of a different view at a social determinant, which is insurance coverage. So here you have health behaviors, 2 that we've talked about previously. The behavior of smoking and behavior of either sedentary lifestyle or poor diet choices that may lead to obesity. And you see this data stratified by insurance coverage. As we've heard from previous presenters, whenever you think about health insurance coverage and what contributes to an individual having a higher likelihood of having insurance, it's usually having greater degrees of education that have been attained. That usually leads to higher income, perhaps more stable employment where they're offered insurance through an employer. And with that usually trends the smoking rate. So you'll remember that in the comments that you heard earlier today, Oklahoma, specifically our data from 2017, is certainly validating those claims. One thing to point out, though, I believe whenever I spoke to you a couple weeks ago, whenever you look across any health indicator, it's not just an easy thing to say health insurance may be the cure-all for everything. Obesity is one of these that you see that it really cuts the chasm across insurance coverage and uninsured, as well as any age group. I believe our Kristen, our presenter earlier this morning, as well as Dr. Raskob, really covered the story of tobacco use in Oklahoma. But again, I would agree with all the points that have been made previously today as it pertains to tobacco use. Obesity, the point that I will make here is that as you look across all of the different demographics or all the different categories, all of the rates of obesity across all of those groups are nearly at or above 30%. So to me, the takeaway here is whenever it comes to adult obesity, all groups are elevated, and that should be especially concerning to us, knowing how obesity does play a role in the development of chronic disease and burdens of disease amongst our population. So to that point, whenever you think about obesity as a potential lead to adult diabetes, as you look here, you see some pretty considerable lines in terms of age groups. The older you get in Oklahoma, the higher the probability that you're going to develop diabetes, as well as those same trends in the green and the peach areas where higher educational attainment and higher incomes are contributing to perhaps a lower prevalence of diabetes amongst those groups. This, I believe, is next to the last slide for me. The appropriate way to read this is among those with diabetes, what rate of individuals would also have obesity. So as you look here, greater than 50% of the population, when we talk about comorbidities between obesity and diabetes, we're far exceeding over half of the population that has diabetes. Okay. Again, this is health outcomes by insurance coverage. The point to be made here is that really, as we talk about chronic disease and how it may lead along a continuum to premature death or potentially preventable death. Whenever we look at health outcomes by insurance coverage, what's striking here is that those that are with insurance coverage are basically the blue bars. You'll notice that there's a higher rate of diagnosis for diabetes as well as for high blood pressure. Now, some people may say, well, gosh, that's interesting, because wouldn't you think that an individual without insurance coverage would also have those diseases? The answer is yes to that. So what you see here is that perhaps this is the actual diagnosis, that confirmed diagnosis that's coming back, that folks are being caught as far as being said, yes, you are afflicted with these potential diseases, but it's also putting them on the pathway to having that access to the affordable treatment, hopefully being able to prolong life, improve quality of life as it moves along the continuum. My last slide is a comparison that I offer to you. This is the slice of health insurance coverage as it pertains to the survey that's conducted by the Health Department, the BRFIS survey for adults. Whenever you look at this picture, of course, U.S. Census Bureau is another good source of information and a wealth of ways to slice and dice that data on who are and are not who are or are not insured. But I did present this to you as remembering that insurance coverage is, as we've talked about earlier, it is one facet, but social determinants really are multifaceted. And in order to move that needle on improving health outcomes, we really have to have a system that's designed to focus on all those facets of social determinants.
Thank you very much. Representative Lawson, your question?
I did, and this is just curious. The first couple of slides you had that broke down by age, race, there was blood pressure or high blood pressure and then hypertension. Is there a difference in those, or is that synonymous?
Sure.
My name is Derek Pate. I'm with the Oklahoma State Department of Health. There's no difference between those two slides other than one of them had the insurance status added to it. So hypertension, blood pressure, high blood pressure are the same.
Representative Fugate.
Thank you, Mr. Chairman. Could you go back another couple of slides to the 65% slide? Oh, that one, yeah. I just wanted a little bit of clarification. So as a state, we are at 64.6%, and then nationally it's 60.5%?
That's
Is that correct?
Mm-hmm.
Okay, so a difference then of about 4.1% between our state and the rest of the United States on average.
That's correct.
Okay, because I had...
Yeah, go ahead.
Thank you. The point I was trying to make there was from our first meeting when I had heard kind of a rumbling narrative that, the fundamental problem we had in the state of Oklahoma was somehow different than what the rest of the United States is facing. And that's not necessarily the case based off of this data. Is that an accurate statement?
Well, you'll have to refresh my memory on what those early comments were, if you would, please.
Follow up?
Well, it was more side conversation amongst some of us who were present that perhaps we had a problem in this state because we were at 65%, and shame on us, quite frankly. But by comparison to the rest of the United States, we're really not that different than the rest of the United States in these chronic areas. Is that a good statement to say?
Well, I think so. We have to remember that this is showing the percentages of deaths that are attributable to these diseases in Oklahoma as compared to the nation. So I think we'd really have to look at that line to see. I'm sure there are other states that are performing better than us or better than the national average, that they would have fewer deaths, right? Without seeing kind of that full spectrum, I can't say exactly where we are at in terms of our 65% of deaths as compared to to other states in our region or across the nation. So that's certainly something that I'd be happy to provide for you all after this meeting, just see where we're at.
Senator Stanislawski. Oh, you have a, okay, follow up.
Just one more. There was some comments that you made about some of the data perhaps being underreported just because these folks aren't getting treatment.
Mm-hmm.
Is that correct?
Mm-hmm.
Okay. Thank you.
That's right.
Senator Stanislawski.
Thank you, Mr. Chair. Also going back to our first meeting, I understand, at the first meeting it was reported that we had a 14% uninsured rate.
Mm-hmm.
And I think there was further clarification on that, but I wasn't at the last meeting. So as I understand it, our Native American population may have health insurance through Native American means, but they're reported as part of that 14%. Is that correct?
That's correct. So the United States Census Bureau defines who is counted as uninsured versus insured. For individuals that are reporting to the Census Bureau that their only source of coverage, only source of health insurance coverage is through an Indian Health Center, tribally operated facility, or urban Indian clinic, they indeed are counted in the uninsured bucket.
Okay. So follow up.
You're recognized.
So just on that then, do we have any idea what our true uninsured rate is then?
Well, so there have been Oklahoma-specific surveys that have been conducted over the past, say, I think since 2004. I believe there were 3 of them that had been conducted through University of Minnesota's State Health Access Data Assistance Center. It was an Oklahoma-specific telephonic survey that was conducted. I believe the treatment of Native Americans was different in that it was captured as an actual insurance category, not classified as public or private, but just captured as a data point. That's something that I believe we can provide some links to those past reports to see how the data might have been different.
Representative Fugate.
Thank you, Mr. Chair. This is going back to the data. I was going back through my notes, and I had noted that we were, in 2017, based off census data, it was 14.5% uninsured, but there was an estimate that perhaps it was current day had gotten worse, and we were really at about 16.6%. At least that's the number that I had written down. Does that sound like what we were talking about?
So thank you for the question and for allowing me the opportunity to clarify for that. So I think what was lost a little bit in translation at that first meeting is that the 13.9% and the 16.6%, I believe, are both Census Bureau sources. The 13.9% represents all age groups. So from birth to those that are greater than 80 years of age. Those are age categories that are defined by the Census Bureau. So 13.9% corresponds to any age group across the spectrum in Oklahoma. The 16.9% is also a U.S. Census Bureau data point. However, it only captures those age 65 and less. So it cuts out the portion of the population that is greater than 65 years of age. That's why you see a slight magnification in the rate because you are looking at cutting off those that are of an age group that have a pretty high probability to be covered under Medicare if they've paid in enough quarters. Yeah.
Okay, seeing no further questions, thank you for being here again, all of you. It's pretty sobering information that we received today, pretty monumental task that we're up against. Just a note, next week, we will start meeting in the Taj Mahal of the Senate in room 535. That's where we will be. Senator McCourtney will be chairing the meeting next week. We both appreciate you all being here, all the speakers and the people here who are listening in to us. Until next week,